Thank you for the message. I just realized I've been muted this entire time. So let's take that again. Thank goodness for editing. Let's try that again. Yo, what up, y'all? Such a call. Smalls here, coming to you from Chumash and Tongvaland, otherwise known as Southern California. And I want to welcome y'all to the intersection of Black and Sick. So before we begin, before we welcome our guests and introduce them, I want to get in. And before we get into today's conversation, I want us to begin, as always, by grounding today's topic and conversation in who we are and why this space exists. With roots in India's late 15th century Punjab, Sikhi was founded during a time of deep political corruption, religious violence, caste oppression, and economic exploitation. This was the backdrop against which our founding guru, Nanak Dev Ji, began teaching the principles of Sikhi, declaring there is no Muslim, there is no Hindu, only one shared humanity united under one divine. The foundation of this faith, the core of Sikhi, is justice, equality, selfless service, or seva, and the sacred duty to resist all forms of oppression. From langar to seva to dying for the right to religious freedom, the Sikh tradition has always required us to stand 10 toes down on the front lines of the fight for liberation. See, our gurus taught us that spirituality is inseparable from social responsibility. So for Sikhs, justice isn't optional, it's sacred. And our Black American ancestors taught us that none of us are free until all of us are free. And that is why, even when the topics that we address here at Black and Sick aren't explicitly about Sikhi or positioned squarely at the intersection of culture and faith, they are still deeply Sikh in spirit. In the face of systemic racism, white supremacy, religious discrimination, state violence, and economic injustice, our commitment to Sarbat Dawala, or the welfare of all, compels us to speak, to act, and to stand in solidarity. So we draw a direct line between the world that Guru Nanak challenged, one marked by fear, division, and the abuse of power, and the one we're living in today, especially here in the US. And as one of our favorite queer icons, Angelica Ross, said, the admission price for community is accountability. You can't claim pride and membership to a community to which you refuse to be accountable to. And this right here, this project is us being accountable to our communities. So if you're here for deep conversation, to help us build solidarity, and to inspire collective action through the lens of Sikhi at the intersection of culture and faith, then you're in the right place. And let's get into it right now. All right, y'all. Despite the mishap, I'm glad we're all here. I'm excited about today's conversation. This is part 2. If you guys haven't seen part 1, you can go check it out with Cass from Sickle Cell 101 and Dr. Mary Seal from UCLA. She's a UCLA hematologist oncologist. And so this is like a continuation of that conversation. But if you haven't seen part 1, it is okay. This one will stand alone. You don't have to see them in a particular order, but they are connected, and it will probably add some context for the conversation that we're going to have today. So I'm going to start by introducing us to one of our guests from part 1. If you heard part 1, then you know this is one of my absolute favorite advocates, one of my favorite people in the sickle cell community and in the advocacy space in general, the founder of Sickle Cell 101, the biggest, the baddest to do it in the advocacy space, Cass Trimnell. Let's see. There we go. Uh-oh. There we go. Cass.
Hi.
How you doing? How you feeling?
I'm good. After that introduction, how could anyone feel bad?
Oh man, thank you. Okay, so I'm gonna hop right to it. For those of you who don't know, just give us like a brief, recap, synopsis about what it is that you do, about your organization, and then we'll hop right into the conversation.
Yeah, I am founder and executive director of Sickle Cell 101. We are a nonprofit organization that specializes in sickle cell education, but also we host data-driven initiatives to mirror what the community priorities are. And yeah, I'm just happy to be here.
Nice. All right, and I'm going to introduce our next guest. Again, I was trying to think of like what's the best story to tell, and I'm not 100% sure, but I thought about the fact that when I was at Sickle Cell Camp with Cass, I told you guys this last stream, Sickle Cell Camp is kind of like a reunion. I don't know if you like would agree, Cass, because sometimes the only time you see other sickle cell warriors, other advocates, is if you're sick and y'all in the hospital at the same time, which is no good. Or if you're like at a conference, right, and then you don't always get time to like hang out and socialize. But camp is another one. Like if you're involved in camp, even though camp is for kids, you can go as a counselor, as an educator. You can volunteer in that way, and so sometimes it's like a little reunion of sorts. And so with me being out of the advocacy space, the sickle cell community for a minute, I got a chance to like meet a whole bunch of new people and reunite with some people that I already knew. And at this point, this was last August. So at this point, I had only met this doctor, not even a year, right? Like it had been a few months since I first met this doctor. And I met her at a time where I was sort of being forced to switch doctors, both because of insurance changes and because that doctor was retiring. And I was really, I don't even know the right word, but I was just, hopeless seems like real dramatic, but I had just given up at a certain point because my doctor just wasn't willing to try new things and just wasn't really up on the latest. And at the time I didn't know he was ready to retire, but I was like, oh, he seems like he's very much ready to retire. So, and something we talked about last time is that there aren't a ton of doctors who specialize in adult care in sickle cell. I think that was something that you mentioned last time, Cass, and that's so true. And so when I met this doctor, I'm sure I had all kind of guards up. I was just like, okay, well, let's see. I didn't know if this was another hematologist oncologist that got stuck with sickle cell patients or what. But when I first when my appointment was first scheduled, I was hearing like nothing but good things, right? Like the person that scheduled my appointment was like, "You're gonna love her. She's awesome. She's amazing." I'm like, "Okay, we'll see. I'll be the judge of that. Like, we'll see, right?" And then I did meet her, and I was like, "Oh, okay, like she is kind of amazing, cool." And then I went to sickle cell camp a few months later, and I find out, oh, she's already famous. Like everybody in the community already knows who she is, and I think that really speaks volumes because there are plenty of doctors and care providers and medical professionals who treat sickle cell patients, but aren't necessarily involved in the community, right? They're not necessarily advocates. Their work kind of just stops at the hospital or in the doctor's office, which fine, valid, fair enough. But the fact that so many people knew Dr. Patel and had nothing but amazing things to say about her. I think it really speaks volumes. I think it speaks more than any words that I could say. So I want to welcome you guys, or I want to welcome and introduce you guys to Dr. Amie Patel.
Hi, that's a fantastic introduction. I kind of echo everything that Cass had already said regarding the introduction. I have been in the sickle cell space. My sister had sickle cell disease, my older sister of 3 years. And so that's been my entire life and my passion to start med school, train in med peds, and be a sickle cell advocate myself.
Nice. And you got right into it. I don't know if you could like tell I was suspicious the first time I saw you in person, but I just remember like immediately I could just tell that you cared, like that you gave a damn about sickle cell, right? And I think Cass, I don't know if you would agree with this, but it's pretty easy a lot of times to tell when a doctor is just kind of going through the motions versus like when they actually care, like when they actually know things, when they're actually up on the research. And you said something, Dr. Patel, that sort of clued me into the fact that you wanted to work in sickle cell, that you specifically made decisions in your career that would allow you to work with sickle cell specifically. And I was shocked by that. I was also like super suspicious. And then you told me, I think I asked why. Like, I think I was just kind of like really blunt. I was like, why? Like, why would you do that? Like, right? Because I'm like super suspicious. And then you told me about your sister. And I immediately was like, got it. Like, that makes sense, right? And it affirmed everything that I was thinking about the fact that like, oh, you do actually care about this. Like you know what you're talking about. Can you speak to us a little bit about your decision to go into medicine and then why you chose to, I believe you did a fellowship specifically to learn more about sickle cell. Can you speak to us a little bit about your decision to do that and why?
Yes. And so I was actually very convinced I was going to be a lawyer for the longest time, and then decided that, you know what, maybe law school's not quite for me. And I felt like in general, you weren't really caring for other individuals being a lawyer. And so I decided medicine was sort of my path. And my sister, as part of her Girl Scout Gold Award project before she had passed away, was that she wanted to start support group sessions. And so she created a support group sessions in Kern County. And she also had the very first awareness annual fair. And after she passed, it was kind of my family's and my like mission to kind of continue with the support group sessions as well as the awareness fair, and ultimately drove my decision to go into medical. And I knew by just working with individuals in sickle cell disease that the biggest gap is what you already had said, the lack of limited adult providers, and really that transition between pediatric to adults. And so I decided to do my residency in both pediatrics and internal medicine, and really focus on that transition of care. And fellowship, I debated for a while if I wanted to do hemonc, and I was like, well, that's another 3 years. And in hemonc, I'd be learning all of oncology, all of malignant hematology, and I wouldn't really be focusing and spending much time learning about sickle cell disease. And so I, thankfully found a 1-year sickle cell only fellowship that was both in kids and adults. And so I did that for a year in Memphis, Tennessee, and met amazing mentors. And now I'm here at UCLA.
Wow. Okay. Yeah, that's amazing. Yeah, that makes a lot of sense. It wasn't until you told me a bit about that story. I didn't have all the details at the time, but it wasn't until you told me that, when you said you're like, I'm actually not a hematologist oncologist, that I even realized, oh, I guess you don't have to do hematology oncology to be a care provider for sickle cell. It never dawned on me. And that day, that I still remember that appointment very vividly, because I remember coming home and just doing a bunch of research. I was like, it just kind of like opened my world for like what was possible in terms of like sickle cell care, right? I feel like for a long time I had been, I don't know if complaining was the right word, but definitely disappointed that we didn't have more care providers who specialized in sickle cell specifically, especially physicians of color, right? And I've talked to them, and I've I've gotten a number of responses, but the main one, surprisingly, that I've gotten most often is that they're like, we go to medical school, we have all these loans, and then you want to start practicing as soon as possible, and there's not a lot of money in sickle cell. And so I've heard this a number of times from different providers, right? And so I'm thinking like, oh, well, that's the same thing the pharmaceutical companies told us. There's not really much money yet in finding, this is before gene therapy really took off, but there's no money in researching sickle cell. There's no money in it. And so that was really sort of disappointing. And I think that's why I was so skeptical initially when you said like you specifically wanted to work with sickle cell. And I am grateful. I've said to anybody who will listen that this is the best care that I've had as an adult, like hands down, period, point blank. Right. It's like the least anxious I feel. It's the most, I feel it's the safest that I felt, right? And I know that has a lot to do with you as a provider, but also the sickle cell program that I found out really exists thanks to you. Can you talk to us a little bit about the UCLA sickle cell program and how that idea came about, and yeah, any information that you can give us about that?
Yes, and so the sickle cell program started October of, I think, 2022. So before I even got there, Dr. Seal was who you had met before in part one, but she was mostly doing oncology type of care, and she decided that she was very interested in sickle cell disease. So there were sickle cell patients here at UCLA. And it was in around October 2022 where there became more of a partnership between MedPeds and hematology to try to provide the most comprehensive care. And so I was hired in November of 2023, and I started. And my biggest goal was really trying to make the transitions more seamless between divisions and departments. UCLA is a huge health system. A lot of things don't necessarily interact, and care coordination between the different divisions don't always happen. And that's including both outpatient and inpatient. And so when individuals go inpatient, care can be very different between different providers, different divisions. And so my goal was to try to unite the UCLA health system into feeling like one sickle cell program that was more cohesive. And that's been my mission. And it's still a work in progress.
Got you. Okay, that makes a lot of sense. Because I was doing a little bit of research, and I did see that you had a fellowship in pediatrics too, which I didn't know about. So that makes a ton of sense. Cass, you were just talking about transitioning and the fact that Dr. Q kept you until he couldn't any longer, and how the same was kind of true for me, but I was kind of forced into the adult world at 17 because I left the Bay for college. So two parts. One, can you talk to us a little bit about your transition, about how that experience was for you? And then the second part is, what would be an ideal transition? What would be an ideal sickle cell clinic or program, from your perspective, either for yourself individually, or like just considering all of the information and data that you have about patients and sickle cell warriors and the members of our community in general. So your transition, and then two, what would be an ideal transition or and or sickle cell program?
Yeah, it's a good question. I had a pretty good transition, and that was because I was kept until I was 25. I wasn't um, discharged, so to speak, when I was 18 years old, and so I had time to kind of find myself, kind of figure out myself as a young adult. Right? You hit 18, and so much changes for you that transition is probably the last thing on your mind. And so I had that additional time to kind of figure things out while I was in college and while I was doing all this stuff. Um, it's the second part of your question is interesting because, for example, I traveled to Jamaica a couple years back, and they don't have transition as a problem at all because they see patients from birth to death, essentially, and they're called lifespan specialists. And to me, that's what makes the most sense, particularly for sickle cell. Now, I know this is additional burden on the provider, right? Because you're specializing in not just pediatric, but adult problems. But Dr. Julie Cantor, she calls herself a lifespan sickle cell specialist. And to me, that's what makes more sense. Like I said, transition is a big problem here in the US, but it's
Yeah.
not a problem in Jamaica, right?
Okay.
And so, people drop off maybe for other reasons, right? But it's not because they're transitioning from one provider to another. And so I think I'd probably advocate for more of those lifespan models where it's the same person you get to know and you build rapport and they watch you grow and they understand you as a person, as opposed to kind of switching over, if that makes sense.
Yeah, yeah, that makes perfect sense. And that is not the response that I thought I was going to get. I'm not sure what response I thought I was going to get, but that makes so much sense, right? Like that absolutely makes sense, because Lord knows if I could have kept Dr. Q my whole life, like I wouldn't have looked for anywhere else, right? I think that makes a ton of sense. And Jamaica is like my favorite place on earth. Most people who know
I
me
know.
know that. And
I
yeah,
know.
yeah, yeah. Jamaica is like my favorite place. And I didn't know that. I did not know that about
Yeah.
Jamaica. So I'm a little bit surprised, but not totally surprised. But see, this is why I love having these conversations, because I'm constantly learning something new. Just when I think, the new knowledge and new information is slowing down, I learned something new. So that's awesome. Okay, so I do think that makes the most sense, because some of the challenges that I have, some of which I now know are kind of specific to me and related to like me being on the autism spectrum, that were major challenges before. So even taking that out of the equation, um, having a physician who knows you, right? Like knows little things. Like I remember Dr. Q wrote me a letter one time, and the letter said something like, her hemoglobin stays around 11 even when she's sick. Like even if she's in crisis, it might not drop. It doesn't mean she's not sick, because some doctors would be like, well, your hemoglobin's too high, you can't possibly be in crisis, right? But like it takes a doctor knowing you and kind of like knowing your history and your patterns and what's typical for you to know those things, right? And it's why I have my spreadsheet that has all of this information, just depending on which doctor I'm going to run into, right? And I think that would solve for so many problems. Even, and you can kind of tell me, like, I would love to know some of the challenges that you have, not just with transition, but like in adult care in general. I think my biggest one is the anxiety that I experience around taking pain medication and dealing with that. I have a video on my channel about the different experience of me trying to go get my meds filled versus my mom going to get my meds filled. Completely different experiences, right? Same thing when I mentioned this last stream, where my mom was diagnosed with breast cancer. And so we had the same hematologist oncologist, went to the same hospital, but our treatment was vastly different. And my mom was the one who noticed it and spoke up and was like, what's going on here? Like, you can't blame it on different facilities. You can't blame it on these being different doctors. What's happening here that the treatment is just different? And I think that that's absolutely the case. I think, one of the reasons I do experience, or I guess the point that I'm making is, if you have a doctor, I work hard to make sure my doctors trust me, right? I work hard to make sure I'm doing what I'm supposed to be doing. I'm not, you don't have any red flags out of me. I'm not like abusing my medication or pharmacy hopping, all the things they tell you not to do, right? I work very hard to do those things. And I think a lot of the stress and anxiety that surrounds that could be minimized if you did have, for a lot of other people, because I know I've recently found out I'm not the only one that has this sort of experience. And when I say anxiety, I mean like I will do everything to procrastinate going to the pharmacy. Like the moment I know it's time to go to the pharmacy, I'm finding all kind of other stuff to do, and I don't always realize it, and my heart starts racing. Like I mean, like real actual anxiety, right? And a lot of that has to do with, well, the pharmacist doesn't know me. They don't know that I'm not a patient who's abusing their meds. Like they don't know, and then I have to make sure I pick it up on this day and not one day early, but then don't run out. And it's like, and I know that there's a difference because I have a pharmacist at home or in the Bay Area who does know me, who knows my history. And when I have a problem with the other pharmacists, or they start asking questions, I just say, hey, can you ask Mindy? Mindy comes over and says, oh, hey, Cams. And she knows me, right? And that makes all the difference in the world. Like even just like my patient experience, it makes all the difference. So having, what you said, lifespan specialist, is that what you said?
Mm-hmm. Yeah.
That's amazing. I think that's dope.
There's a lot of pushback on that, though.
Oh, really?
From the provider point of view, it is additional work, right?
Yeah.
To an already overloaded position or job, right? And so maybe it's finding a balance. Maybe it is expanding that transition age to something a little bit older. But yeah.
Well, that's what I was going to ask Dr. Patel for you to chime in and give your honest thoughts on that. Like, does that sound, because as amazing as that sounds to me, you might have a perspective that says, here's why that's actually a terrible idea in the US, right? Like, I don't know, but I would just love to hear your thoughts on what Cass was just talking about.
So, I mean, technically, I am a lifespan. I am pediatrics and internal medicine, and I train in sickle cell on both. The challenge is, though, right, is finding the job. So it's the health system, not necessarily just the provider. While, there's not many med peds physicians in general. And then with that, then doing let's say someone did hem-onc, doing a combined hem-onc fellowship is also, that's 5 years if you wanted to do the hem-onc route. And if you wanted to do what I did, which there isn't many fellowship, there's the one at St. Jude that does combined. There's only one program. So that's not going to train enough providers to be able to, do a lifespan. And then once you finish, how are you getting hired? So if I'm getting hired in the Department of Medicine, I would have to buy out my time from pediatrics in order to be dual appointed, in order to even practice in that way. And so it definitely makes it a lot more challenging, just as a provider, to navigate the health system that doesn't really know what to do with someone who's calling themselves a lifespan specialist. And so even at UAB, when I had interviewed, it was going to be a lot more of a negotiation in order to get a lifespan type of position.
How did you, I guess, go from being pediatric to, like, did you expand within your position? You started in one position and then expanded into that?
So MedPeds is a residency specifically that is, you do 2 years of internal medicine and 2 years of pediatrics.
Okay.
And so, and that's a specific residency afterwards. And doing fellowship after that, there really isn't a full path.
Yeah.
Or combining it. And so that makes it a little bit more challenging.
Yeah. I have another question, if Smalls, you don't mind. For Dr. Patel, I know you're in a unique position where sickle cell impacts you personally, but then you work as a provider. In your opinion, what is the best way? So I think notoriously those within sickle cell are either impacted or, directly, or, have a loved one that's impacted. In your position and seeing who you work with and other providers, how do we get more people on this side to support sickle cell? Because see other disease states, people from outside the community, if you will, come and support, but in sickle cell is patients and caregivers and siblings and cousins on the front line, and very, very little outside support. So I don't know if that question makes sense, but I'm hoping to understand, how do we get more people to care about sickle cell from your standpoint?
I mean, that's a really good question, and I don't know if there's one fit answer for that. Um, I do know a lot of the limitations in terms of it from the provider's perspective and why there are limited providers who specialize in sickle cell disease. And I guess, the always to solve a problem, the first thing is figuring out what the barriers are.
Yeah.
And it's challenging, right? There's a lack of research for a lot of sickle cell disease. So as a provider, someone's coming to me with, hey, there's all of these different issues, and there's not as much evidence or research to fully treat all the different components of an aging sickle cell population. It's a really challenging thing as a physician to be like, okay, well, you have that, but there isn't really great treatments for it. So that's one limitation. Two, care coordination between the health systems is really, really challenging. And, a 50, 60-year-old adult or even a 30-year-old adult may need to see 8 different subspecialists. And trying to coordinate the care between those 8 specialists is very challenging. And then all the different insurance barriers, with all the other social, challenges, and having that true multidisciplinary team is not fully funded. And so it a lot of times leads to extreme, like burnout and people being like, I don't want to do this because it's so hard.
Yeah.
And so it takes someone who cares and knows the disease and knows the people who are like, hey, actually, this is a really, great group of individuals, and I really want to help and be there. And so, I mean, I think one of the things maybe to address that is more research, which is one thing that people are starting to do and starting to get awareness, which hasn't, 20 years ago, it wasn't in the same position. So I think that will really help. And then creating more of these sickle cell, like 1-year fellowships as well, I think will increase the number of individuals interested in sickle cell disease because it's a shorter timeline. And then the biggest thing, though, is the health system. So getting extra multidisciplinary support that a health system will pay for. So once we figure out that answer, I think you'll have a lot more people interested in sickle cell disease.
I think that makes a ton of sense. And this is exactly why I like speaking to medical providers just as much as fellow warriors, right? All things that I didn't think about, because I think it's easy for me to look and see and say, why are none of the specialists people of color? Or why are there so few people of color? Or why are there so few doctors? It's really easy to be frustrated. And I think those feelings are valid as well, right? And then and still not understand the systems that are at play that really impact the decisions that doctors and physicians are making, right? And so I want to bring in the next doctor here to sort of speak to what you guys were just talking about. So I'm actually going to let Dr. Max introduce himself, but if you can, there we go. Dr. Max, how you doing? So this is a doctor, and I actually think this really speaks to Dr. Patel, right? Because I told Dr. Patel I had a goal regarding my pain meds and what I wanted to do in that department. And unlike a lot of previous doctors who were like, well, there's really not much else you can do. This is the medication that works. You're kind of stuck. And so I felt stuck for a few years. And it was Dr. Patel that was like, no, we have options. Like if you don't want to take these meds anymore, if you want to get off this med, we have options. And so I started to get hopeful. But then Dr. Patel mentioned like pain management doctor, and I was kind of disappointed again. I was like, no, I've heard about the pain management doctors. No, I don't really feel like being judged. They don't really be understanding sickle cell. They don't get it. So there were a few things that were sort of working against me. But at that point, I'd already trusted Dr. Patel. So I said, okay, all right, cool. I'll meet with this doctor. And like many other things, I thought, well, I'll just meet with him and then I'll be able to say I did it and that it didn't work, and then we'll try something else. Sure enough, I was wrong again, right? And I'm happy about it because Dr. Max is the doctor that I met with, and I had trusted him since probably our second appointment, right? And so I really appreciate him for his knowledge about sickle cell, for having that background information, for being patient, for being willing to answer all of my weird questions and give me all of the information, help me understand the science as much as I like to. Again, not all doctors are okay with that, or comfortable with that, I should say, and he really is. And so, Dr. Max, one, I want you to introduce yourself to the people, and then speak to why you chose sort of the career path you chose. Why pain management, and how is it that you know so much about sickle cell? Why do you care about people in the sickle cell community?
Oh my God. That's all of that. That's very kind of you to share. Hi, everyone. So I'm Max. Or Max Jordan Nguemeni. I go by Max, and or Dr. Max or Dr. Nguemeni, depending on the setting. I'm a general internist, and I'm like a generalist. I liked a lot of my rotations when I was going through medical school. Um, but I think I went into medicine being really conscious of like just inequality and like how people are treated unequally depending on like what their background is and what have you. And I think it shows up the most um, when it comes to pain management, because pain is one of those things that it's kind of like subjectively assessed and reported. And so um, it's if there's ever sort of like breakdown in trust or communication between a provider and a team, or a breakdown in like even empathy or whatever, pain is the thing I think where we're probably gonna fall short first. And if you look at the studies, when a patient is having the kind of pain that is thought to be hard to prove, that's where you see a lot more bias. So like when people tell you they're having back pain, but when someone's having like a kidney stone, you see a little less of that, right? Because it's obvious you can prove that this person's having a kidney stone, right? You can't always prove that somebody's having a headache just by like with like imaging or whatever. So uh, the sort of subjectivity around pains, it's something that I just kind of noticed, and in fact, the first encounter that really struck me as a medical student was around pain, and it was this like young Black guy who was my age who had a illness from childhood. That's so he had juvenile idiopathic arthritis, and he was like, I don't know. I think I was a first year med student, so I was 23. He was my age and had already had like 2 hip replacements, 2 knee replacements. Like he had gone through, you know, hell and back because of his arthritis, and so is on chronic opioids. Like, you know, comes to the clinic with a new like ankle pain complaint, and this like attending who is supervising the clinic is asking him questions almost like a prosecutor that's um, cross-examining a witness, right? Have you been selling your opioids? Have you been getting opioids off the streets? Why'd you miss your appointment last week? Da da da. Like, did not believe that his ankle was broken, and lo and behold, his ankle was broken. And I was just so shocked by this. I was like, oh my God. Like I knew, right? Like I came into med school vaguely aware, yes, inequality is a thing, what have you. But like seeing that in real life as a first year med student, I walked out of that clinic that day just disgusted, right? And incidentally, this guy was the person who was like my small group, like faculty leader for musculoskeletal, um, like workshops or whatever. I don't know. It stayed with me. And then the sickle cell thing. How did I get into this? I care about pain, right? It's like I feel like there's a sentence that many people have told me, or told me when I finished medical school, right? Like something like you will rarely cure, um, you will often like I think heal or comfort or something like that, but no, you will rarely cure, um, often heal, but always comfort, right? Something along those lines, where like you can't always cure what someone's going through. You can often sort of manage it, right, with medications, whatever, but you can always provide comfort. And I've carried that phrase with me, and that's one of the reasons why like pain, it's one of those things, right? You can't necessarily always fix the underlying reason, but you can always provide comfort and alleviate the person's suffering. So when I was a resident, um, my intern year actually there is when essentially the Brigham decided to consolidate all of sickle cell inpatient care on their one service, where essentially the attending would be a hematologist, and then the residents would rotate. Um, and because there was this issue where essentially like sickle cell patients get admitted, they're on a bunch of different teams, and the outpatient provider is really the person who's running the plan. They show up, they pull the intern on this team, then they pull the intern on the other team. It's just like very disjointed. So they created this thing after everybody woke up about racism in 2020. And I spent a ton of time on that service. I loved it. I love taking care of people's pain. It brings me so much joy when I am involved in like someone who's experiencing a lot of pain in their care, and then they get better. Nothing brings me more joy than seeing someone who was suffering suffer a little less. So I spent a ton of time on GMSB is the name of the service, and I learned this is where I learned about the ESRD, the end-stage renal disease. I had this 40-something-year-old Black man who came in with a gout flare and incidentally had an ankle fracture, and it was like, how'd you get an ankle fracture? You didn't fall. And of course, he has osteoporosis. And I was like, how does a man get osteoporosis at 40? Of course, it's sickle cell, right? And at the time, I was loving it so much. Everybody was like, you should totally do a hematology fellowship. I don't really care about platelets. I really care about people who have sickle cell disease, however. And I was in the primary care track. And so that's how I was like, oh, I could do primary care and see if I can focus on this patient population, right? Because as Dr. Patel mentioned, it's an aging population. As treatments, we get better at managing sickle cell in the earlier years. Lifespan increases, and I got to inherit a lot of patients with sickle cell disease in their 40s, 50s, 60s who have a ton of other issues, right? Pulmonary hypertension, heart failure, kidney disease, all these kinds of things. It's like, oh, I would love to be the kind of doctor that helps pull all those specialists together on the early side and really optimize your care so that we can help you with healthy aging. That's how I got here. And I was applying for jobs. Every person I was interviewing with was like, can you help me be a PCP for people living with sickle cell disease?
That makes a lot of sense. Okay, that makes so much sense. Cass, you're gonna have to get out of here shortly, which I'm disappointed because there's so many things that I would love to talk to you about. So much of what Dr. Max said in terms of pain and what we know about the history of pain in the U.S. and the healthcare system. And oh my goodness, there's so much to get into. But like I told y'all last time, Cass is famous. She's on a world tour, so she has to go. Okay. I'm joking, but also I'm not. That's how Cass is in my mind. That's why I be fangirling. Okay. So Cass, thank you so much for joining us for part one and for this part. Hopefully we can speak again and speak to a little bit, especially since we got Oakland in common, right? We need to speak to the Black Panther parties and the Black Panther Party and what they did for sickle cell. So hopefully you'll have us back. We'll be able to continue this conversation. But before you get out of here, can you let people know where to find you, how to find Sickle Cell 101? And just so y'all know, if you need to know anything about sickle cell, anything about sickle cell advocacy, that's where you need to go. Sickle Cell 101. Trust me on that. Cass, where can people find you?
Thank you. Thank you so much. I really appreciate it, Smalls. And I just want to quickly say, I hope we can continue the conversation. I feel like this should be a series, but we'll try and make it work, right? So you can find us at sc101.org. We're also on social media. That's where you find a lot of our information is evidence-based information, and we disseminate it through social media. We disseminate it through a newsletter. So Sickle Cell 101 is the handle, and feel free to send us a message, info@sc101.org. And thank you so much for having me. Wonderful to meet both of you, and wonderful to be on your show, Smalls.
Thanks so much. See you soon, Cass.
So,
all right. So much. There's so much. I don't even know which direction to go in first, but I think it explains a lot about why you got into sickle cell or how you got there. I was going to say we know, but I think the assumption is that people know the history of U.S. healthcare, but I'm finding that people really don't. The book that I always recommend is there's two books. One is Body and Soul by Alondra Nelson. It sort of tells the history of. Yeah, I love this. It tells it's called Body and Soul: The Black Panther Party and the Fight Against Medical Discrimination. Sort of tells the history of sickle cell advocacy in the U.S. and how the Black Panther Party is really responsible for so much of it and so much why we're here, and how the government does what it does and try to thwart those plans. And then. But I still think there's a lot to learn. I think it's so interesting because so much of what Dr. Max and Dr. Patel have spoken about today, read that book. Like it all connects. And then the other one that I always recommend is Medical Apartheid by Harriet Washington. Especially anytime I have like a not so great experience in the hospital, I usually try to give thank you cards to nurses and doctors. And I will, if I have a not so great experience, I will say, you need to read these two books. Thank you. I don't know if anybody's done it, but I do suggest those two books. And that's because
sorry, go ahead.
Go ahead.
No, I was going to say, I've been thinking about convening a book club for hospitalists, but I have the two books there. I've been reading like everything that I can about sickle cell in the social science literature. There's a history book by Keith Welu called Dying in the City of Blues, which is essentially the history of sickle cell disease through the lens of Memphis, because Memphis was such a healthcare hotbed. I mean, St. Jude is in Memphis. And then there's another one called Uncertain Suffering. That's an ethnography of sickle cell disease across California and Pennsylvania. And they both sort of like address, like, Keith Welu's book is the history of how we got here, right? Like people confusing sickle cell for malaria, whatever, what have you. And then Uncertain Suffering is a lot more about doctors not knowing how to deal with uncertainty and how much uncertainty there is when you're taking care of people with sickle cell disease, and how that influences their care, the experience the patients are having, all that kind of stuff. Anyway, those are my two favorite books that I've read so far specific to sickle cell.
Okay. I'm gonna look that up. The one about the music, the Memphis, the City of Blues, I just got real excited. It's probably gonna move up to the top of my TBR list. Okay. Okay, so I mean that all of that sort of connects into what I was saying though, which is that our history is really complex. And when I say our history, I mean both the U.S. medical system and our healthcare system, but also sickle cell advocacy and the discovery of sickle cell, and me finding out that they're studying sickle cell, but they're not necessarily studying it to treat sickle cell patients. They're learning more about these other illnesses, and I'm like, what are you talking? It's really complex. And something that I said in part one is that the social justice aspect, and for me, that is sort of an umbrella for all of the things that impact sickle cell care and the treatment of sickle cell patients, whether that's implicit bias or racism or, discrimination or, like, again, medical apartheid. All of those things factor into the care that we receive here in the US, but then also our quality of life, right? Like, even though I was 7 and I was like, oh, I'm going to find a cure. I'm going to be a doctor. I'm going to find a cure. And then I realized I don't like school or science. That's not going to work. I was probably in my early 20s when I realized I don't necessarily even want a cure. I don't need a cure. I would just like a better quality of life. I would just like to not have anxiety about going to the hospital. I would just like to not be called a liar, or for people to not assume that I'm not in pain, or to try to use my blood work to tell how much pain I'm in. Or if I tell you I'm at an 8 and you're saying, yeah, but you're reading a book, and I'm like, okay, I would just like for those things to be better for myself and for the rest of the community, right? And so it sounds a lot like, because I don't think either of you have contradicted this idea that most people go into sickle cell, there's a personal connection. There's something gets them there. Even Dr. Seal was like, oh, I had a mentor who was working on research, and there's some sort of personal connection. And it sounds like, based on what Dr. Patel was saying, and just what I've heard from Cass and people in the community, it sounds like we really, and I'm saying we, right? And I don't know how much impact or influence the patients would have, but it sounds like we as U.S. citizens need to really, I guess, work on changing our system to make these things more possible, to make lifespan providers more feasible, right? To make the little ways that we can improve our quality of life, to make them a little bit more of a reality, right? And I just want to speak quickly about, so for those who don't know, because again, I'm assuming everybody knows, but that's not true. People still have never heard of Henrietta Lacks, right? And so actually, I'll do it like this. A few years ago, I was in the hospital in the Bay Area, and this was before I had a Hickman, a PICC line, right? And the reason I didn't have like a Hickman or a PICC line or a port for the longest, I found out later, was because they didn't really, the doctors that I had before didn't really trust me to be walking around with like a PICC line, or, because I guess I could go somewhere and do drugs, right, and get high that way, and right. I found that out later. But before I got my PICC line, I'm in the hospital, and for those who don't know, my record is 17. That means 17 attempts at getting an IV before it's successful. That's my record, 17. Okay. If you never had an IV attempt, it hurts. Like, it still hurts. Like, I'm deep in my 30s, and it's not comfortable, right? Like, it's not the worst pain in the world, but it still hurts. And there was a lot of anxiety. A lot of times I would avoid going to the hospital, avoid going to the ER, because I know that the hassle of trying to get an IV was like gonna make everything worse before it got better. And I'm in the hospital. One IV had gone bad. They call in the big boss nurse, the specialist, and she's being so rough. And I'm just like, I'm trying not to cry. I don't like crying in front of people, but I'm starting to cry. And she's like, oh, she's like so sweet and so gentle. And she's just like, I have to be rough because, your skin is thicker. And I was like, wait, what? It like threw me off. And I said, because, you hear about that stuff, but like I had never experienced it. And it was just so weird for her to be so like nice and kind and like seemingly caring, but then tell me that she had to be rougher when she was trying to get my IV, because as a Black person, my skin is thicker. And, but I got it. Like, I don't remember her exact words, but it was very much like, but you got it though. Like, you can handle this. Like, you're one of the toughest patients, right? And I'm like, I probably look like that, but inside I'm not. Like, what are you talking about? And I'm saying that just to say, like, there has been this notion for the longest that stems from, back in when slavery was a thing, that Black people with Black skin feel pain less, that we, have a higher tolerance for pain, that our skin is thicker, that we basically need to be treated differently than everybody else because we have dark skin, or because we're Black, or because we're of African descent. And these are ideas and things that still permeate. Like, she was definitely an older woman. I think she's probably like in her 60s, maybe even close to 70s, right? But those ideas came from somewhere, and she's not the only person in the healthcare system who thinks these things. And so I figured I'd rather tell that story than just give a bunch of stats, because those things happen, right? It's why I don't have a bunch of tattoos, because finding somebody who was like, and I'm grateful now, but finding somebody who was able to give me a tattoo without leaving scarring because they're just digging so hard is just like, it's wild. And so a lot of these attitudes and ideas and thoughts, they still persist even to this day, right? And so I can't speak to like how grateful I am. Yes, to be clear, just because somebody is a person of color, doesn't mean that they're automatically going to be a better physician. But we understand the idea of like, working twice or three times as hard to get half as much. And we also know that statistics and data shows that female physicians, have better outcomes. So I'm just saying, there's some numbers and stuff there, right? So as we wrap up here, because again, I'm hoping that we can continue this conversation at another time. I have a couple of questions for both of you. One, what's a goal, an idea, an accomplishment, a milestone, anything like that you have, either for the U.S. healthcare system in general, for sickle cell, for your career in sickle cell, for your career in advocacy, anything like that? What's the goal that you have? And the way I tell people is like, think about the world that we have now, and then envision the world that you want. Envision the world that you think that we deserve, and then how do you get from point A to point B? But tell us a little bit about what is something that's part of the world that you envision, the future that you envision, whether it's healthcare, whether it's sickle cell, whether it's a personal career achievement. I'd love to hear from both of you on that. Whoever wants to start first.
Dr. Patel, go.
I was going to say, you go ahead, go first. But that's a great question. I know I definitely have my goals here at UCLA, and then there's the goals that are more, I would say bigger than just UCLA, more health system and systemic changes that are needed. One of the things that I was kind of highlighting before is that I truly think that one of the reasons why adult care is really, really challenging beyond the lack of providers, is that there's also just lack of support and resources once an individual enters the adult system. And the emphasis on a multidisciplinary team is kind of forgotten um, when patients have the most degree of complications that they've ever had in their life. And I think that restructuring the health system that prioritizes multidisciplinary system. So that means starting to bill for, your social worker, your patient navigator, your different coordinators will make it a little bit more enticing for a health system to be able to onboard these individuals, and then actually having a multidisciplinary team that can best serve the patients and also help the providers and ultimately help even the health system at the end of the day.
Got it. And Dr. Patel, with you also being famous, like I mentioned at the beginning, you got to get out of here soon. So I want to ask you one more question before I let you answer, Dr. Max. I always tell people, like, I want to be my nurse's favorite patient when I'm in the hospital, right? Like, and I'm like half joking, but I'm also kind of serious in that, like, I know that my care is in their hands, and I always want to be as respectful as possible to nurses. But I also say that because I really would love to bridge the gap even more between physicians and care providers and patients, right? Because I strive to be like my nurse's favorite patient, I often hear things that I think maybe the average patient doesn't, right? And so I will hear nurses not necessarily complaining, but sort of like opening up and being sort of transparent. And then I hear from patients like, well, doctors don't do this and doctors don't do that. And so now I'm like, oh, I wish they knew this and I wish they knew this, because I think you guys would understand each other a little bit better. I think that if you guys, had more information about each other's perspectives, you guys would understand each other better. There might be some better relationships there. Maybe that's me wishful thinking. I don't know. But the same is true for my doctors, right? Like I'm trying to be my doctor's favorite patient, in that not just favorite for the sake of favorite, but in that I'm doing what I'm supposed to be doing, right? I'm taking my medicine. I'm showing up to appointments on time. I'm still working on that. All of these things, right? Dr. Patel, what is your ideal patient? And again, I don't necessarily just mean like, oh, they're funny and this, that, and the third. I know Dr. Seal mentioned that, she learns a lot from patients, and so she loves when patients ask questions, but it can be that, it can be anything. What's your ideal patient? What do you wish patients knew?
I mean, you're fantastic as a patient. So,
Thank you.
But you definitely go above and beyond. For a patient, just someone who's truly just engaged in their healthcare. And I know that may not always be the case at all aspects of their life, right? I mean, mental health is a challenge, and sickle cell disease is a chronic illness. And so you may not always be at your best, but someone who's willing to be understanding and work with the health system, and ultimately, having a goal and vision that they want their life to be, and how we can best work together to get them there.
That makes a lot of sense. I think you're I'm trying to be mindful of my words. I'm trying to be intentional about my words. But I think that of all the different type of care providers I've seen and doctors I've had, you make it a lot easier to be a patient with a chronic illness. And so I wish more doctors, I low key, I wish you could be like everybody's doctor for the sickle cell community. Because when you hear, terrible stories, I want to just be like, my doctor's amazing though. Can't you just have my doctor? Can't you just come to UCLA? Right. But then the other thing is, having a doctor and a medical team that you can trust, that is also understanding, that understands that it's a chronic illness, and that I might mess up here and there, but I'm trying, or that is encouraging. And I say that because I know I'm only going to speak to the Black community, because a lot of times we'll say, oh, this is especially true within the Black community. I don't know. It might be true for every community, but I'm only going to speak to mine. I know that there's a lot of mistrust, right? I know that there's a lot of questions. I know that there's a lot of second guessing. We haven't been treated the best. And I understand all of that. And I think you do a good job of being empathetic, of showing up, of being patient, of communicating well, and making it so that I feel comfortable, doing the things that I need to do as a patient to be a good patient. Because like I said, I've had the doctor where I sort of just give up, and I'm just like, well, you're not helping me, and maybe I could be doing more on my own, but I'm not. And so you who you are as a care provider and as a medical professional really encourages me and excites me and motivates me to do more and be a better patient. So I thank you for that. I appreciate it.
Thank you for being so on top of it. I actually tell other patients that I'm like, wow, they're like, oh, I don't know how to stay organized. And they're like, I should probably have a binder. And I'm like, I do have an amazing patient who has a binder and is the most organized and is really on top of everything. And so I do use you as an example.
Thank you. I wish I could. I made a template so other people can have it, but I'm I don't know how to get it to them. But I wish I could just go around helping patients get organized. That would nothing would make me happier. So thank you for that. Thank you, Dr. Patel. I appreciate you joining us. I appreciate your time. If folks want to get in touch with or to learn more about the Sickle Cell Clinic, whether they're sickle cell warriors, care providers, members of the community, or just have questions, is there a way that they should do that?
Yes, you can send an email. Should I say it? It's sicklecell@mednet.ucla.
Okay. I have it. I'll add it at the end. I'll add it to our description and I'll add it on screen at the end. Perfect.
All right. Well, thank you.
Thank you, Dr. Patel. See you soon. Stay safe. All right, Dr. Max, just you and I, before we get out of here, we're going to get out of here shortly, but I had sort of the same question or similar question. Well, actually, first, I know how I work with you, right? In terms of trying to find an alternative. See, that's the only thing about being here in LA. I can't close the doors and the windows. So if you guys can hear the chaos outside, my apologies. It's too hot to be closing doors and windows though. But I know how I work with you, right? Do you see patients in other settings? Do you see patients in the hospital? Do you see patients in person in clinic, or are you mainly just doing pain management these days?
Oh, I do primary care.
Okay.
I do a mix. So there's some people with sickle cell disease who I'm their Dr. Patel. I talk about their kidney disease. I do their whole sort of thing. And then there's some people who I only do pain management for that maybe Dr. Patel sent to me. I'll occasionally do urgent care for anybody. I do street medicine. So once a month, I go around West LA. Through UCLA has a program called Homeless Health Collaborative.
Okay.
It's a van that goes around. It's not one. It's multiple vans that go all over Los Angeles, and I'm usually assigned to the West LA. When I do it, I do it once a month. I just this past weekend, I was at the Salvation Army on Saturday. People who don't have a doctor, who happen to be homeless, need care, they'll just pull up on me, and I'll assess whatever they need, and then.
Wow.
So I love street medicine. It's super fun. When my patients are hospitalized, if I can, I try to go see them. If there are issues with them, I try to be a bridge between them and the hospital team. And I'm sort of in the middle of getting my board certification in addiction medicine. I think I've mentioned some of this to you earlier. A lot of what I do is around pain and suffering. Which is why I'm interested in addiction, because a lot of people who either have chronic pain or sort of complex pain related conditions are stigmatized as are they drug seeking or whatever. But and I think it's actually a very similar experience that people with substance use disorders experience when they come into the healthcare system, right? They're oh, they use heroin or whatever, and people don't nicely. It's often similar when someone who lives on the street comes to the hospital, doesn't get treated nicely. I recognize these patterns, and that's why I also want to be an addiction doctor. That's why I do street medicine. I essentially have gravitated towards the patients that people don't tend to want to take care of. I found it super rewarding.
Yeah, it sounds like that. As you're describing what you do, I'm oh, this man is a unicorn. Okay, got it. Because
it's fun. I think it's super rewarding when nobody wants to take care of someone for any given reason, and then I show up, and then it takes me just 10 minutes for them to be okay, fine, I'll do what you said, and then they feel better. It's yay, the power that has, as
Yeah,
it's nice.
that's what happened when Dr. Patel referred me to you. Like, she's telling me about this particular medication, and in my mind, for those who don't know, I used to be a pharmacy tech. I was a pharmacy tech for about a year and a half. That was totally by accident. I had moved to the Northeast, and I went to go apply for a different job, and they asked me if I think I went to go apply for, like, I was a photographer at the time. I went to go apply for the photo department at Walgreens. I just moved, and I was like, I need a job real quick. And then they asked me if I'd work in the pharmacy, and I was like, I don't do science and numbers, but I'm glad I did. I learned so much. But I think the most important stuff that I learned was the stigma. About stigma, was about how people are seen, was about the fact that not all medications are created or treated equally. And what I mean by that is, like, you could have two medications that sort of function similarly or maybe do the same thing, but there might be stigma attached to one and not the other, right? Or I know when we would hear certain things like Suboxone, people automatically go to addiction. Oh, you're an addict and you're trying to, like, that was just the automatic thing. And so I remember when Dr. Patel was like mentioning these medications, and I'm looking them up, and I'm like, okay, look, I have enough problems. I don't need anybody thinking that, like, I'm an addict. Like, that's the last thing I need, right? And it wasn't until I actually met with you and saw, oh, this is a Black man. Okay. That kind of already like let my walls down a little bit, like let my guard down a little bit. And I was like, okay. And so I was able to listen, and then knowing that you just were not clueless and ignorant about the fact that these medications do have stigma, like, that alone is a big thing, right? Because if you're dealing with a doctor who doesn't understand this, who doesn't understand how me being on a particular medication is going to impact my overall experience, right? When I go to the pharmacy or somebody hears about a particular medication, it is tough. It's difficult, right? And I don't always want to have to be like educating the physicians in nature. So the fact that you're aware is already a huge bonus.
Yeah, it's super. I mean, my research, I study essentially stigma around pain and medications for opioid use disorder. That is what I do for research, or some of what I do for research. So it's super helpful. I'm lucky that, like, I'm able to essentially have a clinical practice that is very much aligned with, like, my research or academic interests.
Yeah, that's dope. And then this is the question that I got, like, at least two more questions after this one. But this is the question that I ask pretty much any medical professional that I get a chance to talk to. What's your ideal patient? Who's your ideal patient? What are they doing? What are they not doing? What are they saying? What are they not saying? Talk to us about, like, that.
You know what's interesting? I don't necessarily think of, like, an ideal patient. It's funny. I have really thick skin. There are patients who will get under your skin, right? Like, patients, like Dr. Patel was kind of describing, like, they're like, sometimes people aren't engaged, and so the way I approach care is more like, how do I get to the bottom of this, right? If I meet someone who's clearly not engaged in their care, to me it's like, there's something else going on here, and how am I going to get to the bottom of it so that we can have a working relationship that actually helps them. And it is really rare that I get frustrated with a patient, and I'm just like, you know what, it's your body. Like, even when the patient disagrees with my advice, I'm like, you know what, you're allowed to make bad decisions. I'm just here to accompany you in this journey as a co-pilot, or, you know what I mean? That's kind of how I think about it. It's like, my job is to present you with all of the information that's necessary, as long as but you gotta allow me to present you with that information. And then if and then for you to sort of decide which of these options that I'm offering or that I'm presenting to you suit you the most. I mean, you would know. How many times have we switched medications, right? Like,
yeah, I was just gonna say that you're describing that, and that is exactly my experience, right? And it wasn't one that I'm expecting. I'm so used to doctors just sort of telling you what to do, and then me sort of having to, because I've never been the patient who's just like, tell me what to do and I'll do whatever, right? That's never been me. Like, I need to understand. I want more information. I want to be okay with it, blah blah blah. And so I'm used to doctors just telling me what to do, and then me sort of having to figure out how to finesse and ask questions so they don't think I'm, like, insulting their ego, or like they don't think I'm, like, undermining their authority or questioning what their education, because it's never that. It's more about me understanding, right? And, like, I never had that issue with you. And yes, we've done a lot of changes, and you also are very aware of my goal to, like, to be off of a particular medication. And so you're really working with me in ways that a lot of doctors haven't. Like I said, the doctor that the hematologist that I had before Dr. Patel was just like so unwilling, just so like not budging. And like that's why I say like having physicians and providers like you guys really makes it's really motivating in terms of like, oh, I want to be my best self. Like, okay, I could exercise a little bit more. Like, let me take care of myself a little bit better. Even though I tend to do that, like, period, but like I can fall off, I can get lazy, but like having a doctor who's willing to give me all the information, not just say, this is what I know best, do what I tell you to do, but hey, let me help you understand how it works, or let me help you understand all these different things, so that, and you told me that, like, you were like, I'm the co-pilot, like you're the pilot, I'm here to like help you navigate, and I've seen that in your actions, not just your word, right? And so that makes a lot of sense. That I appreciate that. That's your response. It is not surprising at all.
Yeah, I mean, that being said, obviously everyone, like, we're human beings who falter and
Sure.
have emotions and all that. I think the only time where I've like actually felt really frustrated was when I felt disrespected, in a way that got in the way of me being able to deliver the care that I needed for this one patient, right?
Got it.
If someone is disrespectful, and it's like, okay, but I'm still like, it's okay, this is what we're gonna do. I'm like, roll with the punches. But like when it's like when when I mean, it's really rare that this happens, but when there are instances where essentially a patient might be a little disrespectful, and that essentially like inhibits me being able to provide the care that I believe is best, then it's like, well, I can't do my job anymore, so that I can't be a doctor type thing. That's essentially the one instance where I'm like, you're not the ideal patient, because I can't be a doctor. Anybody else, I can be a doctor. As long as
Yeah.
I'm again, wanting to hear what I got to say.
Yeah.
I have to do what I say. I told one of my patients recently, you got to do nothing but say black and white. Anything else I'm telling you, like, you can take it or leave. It's
Yo, that's so true. It's funny you said that, because yeah, for sure, I definitely grew up hearing that, right? I did nothing but stay black and die, or stay black, pay taxes and die, depending on how you were raised. But also, and that kind of actually brings me to the next thing that I kind of want to talk about a little bit. But yeah, I mean, that makes a lot of sense. And I think it's important that patients have a lot of autonomy in that sense too, right? And feel that they are the passenger. I think there's a couple of reasons why, and I think it's sort of my perspective as a member of the community, like as a fellow patient, but then also as like an advocate. And just for context, for most people know this, but for those who don't, like, I started doing advocacy work in third grade. I believe I was 7. And I've done some form of it ever since then, whether it's working with Children's Hospital on like research projects and like presenting that research at conferences, or just going to conferences or workshops or whatever. And so I'm constantly hearing from the community, is what I'm saying, right? And I have found that, like, when there are sometimes patients who, when they don't feel like they have a say, when they don't feel like they also tend not to take ownership. And this is not for everybody, right? Like, but I do find that oftentimes, like, if patients can be more involved in their own care, they also can be more motivated. Again, this is some more motivated to do the best, to stay on top of things, to make sure that they're taking their medicine on time, or doing whatever research they need to be doing, or going to physical therapy, or doing the extra little things, right? It's the little things. Anyways, okay. So speaking of not having to do anything but say black and die, I was doing research, right? And for sometimes I'm researching a guest, and it can be difficult, right? Like, the name is just like, like Patel is like the Smith.
There's so
of like,
many, yeah,
right? Like, there's so many
yeah.
Patels, right? But you have a pretty unique name. So amen to that. It's one reason I started going by Smalls, because I realized my government name, I was like, that's a little bit too specific. But I found out that you have what I call the trifecta, which means you went to an HBCU, but you also went to an Ivy League. And I do admittedly have a little bit of bias against like Ivy Leagues, but I have a huge bias for HBCUs, right? I'm an HBCU grad myself, as somebody who was very often the only Black kid in class or the school or whatever. The moment I discovered that HBCUs were a thing, I was like, I must go, right? And so that's how I went to Xavier University. But tell me a little bit about your decision, because we didn't get a chance to talk about this, about your decision to become a physician in the first place, to go to an HBCU, but then to go to medical school, to become a doctor. I mean, of all, and the reason I bring up the whole trifecta thing is because I have found that folks who can accomplish that, can go to a top tier HBCU, and if I'm not mistaken, you went to the real HU, right? You went to Howard.
Yeah.
So that was on the top of my list. But and then you went to an Ivy, and so that's why I say the trifecta, because I found that folks who do that, you can do anything that you want to do. Like, you can do just about anything that you want to do. It means you clearly have the capacity, the intelligence to do the work, to get it done, to do all the things that you need to do, because that's really no easy feat, if we're being honest, right? Like, because you can have the intelligence and not have the work ethic, or you can have the work ethic and not the intelligence, or whatever, but you've got the full package. So how did you decide medicine, and then I'm going to work with the most vulnerable, often forgotten populations? How did you get there? We know you're a Superman now, like we know you're a unicorn now, but how did you get there?
That's funny. So I mean, I went to Howard for undergrad, and the main reason. So I was born and raised in Cameroon. I moved to the United States to go to college when I was 16. I'm mainly my dad's oldest brother has been in the U.S. since he was like in his 20s or something, I don't know. And like my parents sent me to the U.S. like because it's more opportunity here compared to the small country where I grew up in. And then I was at Howard. I was an engineering major because my dad told me to study engineering, and like I didn't necessarily like love it. Like, it was like intellectually it was fun because I like math and physics and science or whatever, but I wasn't like enamored with the practice of it when I did internships. So then I went to grad school doing bioengineering because I was like, you know what? I used to want to be a doctor. I realized this was in high school. When I realized how long it took to become a doctor, I was like, hell no, I want to make money after college.
Same.
How much of a fool I was, because here I am today, still. So I went to grad school. I was like, well, I used to want to be a doctor. Why don't I like kind of do this pivot where I'm going to apply my engineering skills to the biomedical sciences without having to go through med school, right, and residency and all that. And then I was in grad school, and I realized, like, I really want to be, I still kind of want to be a doctor, and that's how I decided during grad school to apply to medical school. Essentially that's my story, and part of it was that in graduate school, a lot of work that I was doing bioengineering, right? So medical innovation. I had this kind of moment one day where I was like, man, I'm working on these technologies that may not be available for actual use, like in my lifetime, who knows? But then also, if they are, they may not necessarily be nearly as available for people like myself, right? Like, because just knowing, like, if you think about the life expectancy gap between Black men and white men in this country, it is huge, right? Access to,
Yep.
And I was like, I am actually less interested in technology that isn't necessarily accessible and like extend lifespan. More interested in closing this gap. And I was just like,
Yeah.
you know what, man? I'm gonna go to medical school and sort of think about how I'm gonna do this, right? So like from the day I stepped into medical school, I have been interested in essentially thinking about how do I help people live longer, like people who have not been able to live longer lives. How do I help them live longer?
Yeah.
And so that's why, people with sickle cell disease, right? Like when you learn about sickle cell in med school, it's like, oh, life expectancy 45 or whatever, right?
Yeah.
Worse yet if you're a man. Yeah, that's kind of how I ended up here.
Gotcha.
Yeah.
Okay. That makes a ton of sense. Yeah. That okay, so that's interesting. A lot of things caught me there. That's a story I hear about a lot. You need to go into engineering, or your parents sort of leading you down a certain path. I think that's how I went down medicine. To be fair, I'm the one who said like I wanted to be a doctor, but the moment I said doctor, my mom was like, "Got it, doctor. You're gonna be a doctor." And so it took some. I liken it to like coming out when I had to like tell my mom like, "Hey, by the
I'm not
way,
doing
I
this."
don't want to be a doctor anymore." Like I shadowed the pastor's wife, who was like the head of like pediatrics at the time, and I was like, "This looks like nothing I want to do with my life." And so that's that's very interesting. I'm glad you found your way. I'm glad you ended up finding your way back to medicine, because I can definitely tell you we definitely need you as a physician. And it's funny, I didn't know you were from Cameroon. I was looking it up, and for those who don't know, like I have a special interest in language and linguistics, so I'm very often trying to figure out where somebody's from, or at least where their name is from, right, based on like their name or whatever. And so I did get close. I didn't nail it, but I did get close. And Cameroon is the name that I get called most often when people get my name wrong. So
Really?
I
That's so funny.
don't know why. But growing up, like I had a godfather who never called me by my first name. He would just always go Cameroon, like just like that. And then anytime somebody gets it wrong, they're calling me Cameroon. It never fails. So yeah, so I will not forget that. Okay, so how did you first hear about HBCUs though? How did you hear about Howard, and what made you? Yeah,
My
how'd
uncle
you
went to
hear about
Howard.
Howard?
Like my uncle and his wife went to Howard, so it was like a no-brainer. They're like,
Oh,
you're going here, and then if
got
you
it.
don't like it, yeah. And they live in DC, so it was
Okay,
nice
okay,
for me.
okay.
And I was 16 years old, right? So I lived at home
Yeah,
my freshman year, and I loved it. And I was like, can't wait to move on campus. I'm not transferring nowhere. So it was more like family. They were like, you're going there, and I was like, okay, great, let's do it.
got it. Got it. That makes sense. That makes sense. Yeah,
Yeah.
that was the opposite experience I wanted. I wanted like a really small school. Howard, we went to visit. It was really overwhelming. I was like, oh, I can't do. I didn't think I wanted to do DC, so that's how I ended up in New Orleans.
Gotcha.
Even though I didn't want to do medicine anymore, because I chose Xavier under the guise that I was going to be
Right,
pre-med.
because Xavier is a big pre-med factory. Yeah.
Exactly, pre-med, pre-farm. And so that's what most people know. XU as being pre-med, pre-farm. So but I'd already chosen the school. I'd already fallen in love with it. I really very much needed a smaller community, but I think this actually speaks to because a lot of times I find that there are a lot of people within the sickle cell community who are still to this day somewhat surprised that like I left home at 17, went away to college, and because I had a lot of family members who were very upset with my mom for letting me leave home for school, who were, telling her it was a terrible idea. Why are you letting me, why is she letting me go away? What if I get sick? And my mom was like, okay, and what if she's 30 and gets sick? Like at some point, like she's gonna have to like be on her own, right? But what I found and what I think made my mom more comfortable and what made me more comfortable, I mean, I was leaving regardless. Like I was just ready to be around nothing but Black people. So I was leaving regardless. I was leaving the Bay regardless. But I think what really helped and what made me choose Xavier over all of the other ones I visited, including Howard and Spelman and kind of like the most popular HBCUs that we know about, is the community. It's the community aspect. It's the fact that like when I got to Xavier, we ended up in the wrong building. We were looking for something. We ended up in the wrong place. And the workers there were just so kind, so accommodating. Of course, my mom's running her mouth. She's telling them about sickle cell. And they're like, oh, yeah, da, 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 da. And so I ended up going to a summer program there. And they really took care of me. Like they really were, because I didn't have family in Louisiana. Like they really were family away from family. And it made my mom feel a lot more comfortable. And I really wish that a lot more of our members of our community had that. I really wish that as much as I wish that we had physicians like you all over the country, right? Like, and so that folks aren't traveling 2 hours to see somebody who specializes in sickle cell, and not 2 hours because LA traffic, but like 2 hours because that's how far away they live in
The physical distance.
Yeah,
totally.
I find that so many of our warriors, how do I say it? Like growing up, my mom would say, you can't want better for somebody than they want for themselves. But at the same time, I often feel like that's the case, but not for any invalid reason, right? Like it's for a very valid reason. If they're constantly told they can't do this, or if they're constantly sick all the time, if they're not getting the best care, if they don't have a lot of community support, if they don't have a ton of resources, I can understand why somebody maybe want to stay close to home, or maybe doesn't see a very bright future, or maybe has a very dismal outlook on what their future is going to be, or maybe it doesn't include college or sports and things of that nature. I guess the question is, and I think this applies based on what you do, not to just people in the sickle cell community, but you serve vulnerable populations in general, right? Like from unhoused people to people dealing with pain in general that maybe other folks aren't taking serious. And so I guess my question is, what do you need, like in between the world that we have now, between the reality that we have now and the future that you envision for everybody? What's something that you really think that we need to start making those strides, to start making those changes to get to the future that you think that we need and deserve and that you want to see?
Yeah, I think one of the big things is like, so I think I'm like a systems person. I like to think like at the higher level, and I'm going to explain my rationale here. Sickle cell disease is a rare condition, right? Like, and so on average, unless you go to med school in New Orleans or Atlanta or New York, like places where there are a lot of people with sickle cell disease, you could graduate med school never having seen somebody with sickle cell. Graduate residency only having seen like 2 patients with sickle cell, because it is a rare disease, right? So it's like 100,000 people in the United States across 50 states. Well, maybe across 30 states, because there's like 20 states where there's like no Black people. Not to say it's a Black disease, but you know what I mean.
Yeah.
But so what does that mean? How does the care for someone who's living with sickle cell disease, or for someone who's, say, living on the street, or someone with a substance use disorder, how does their care remain adequate or whole when they meet a doctor or a nurse who's never seen somebody with their condition, right? And the answer to that, to me, has to do with time. I was just talking to a doctor not super long ago. He's like, listen, I'm so glad to have you here. Well, I was in residency. I only took care of 2 of these patients, so I don't know what to do. I don't know how to talk to them.
Wow.
And we rotate quickly. We have a bunch of other patients, so like, and because I was essentially like, well, you need to go in there and build a relationship with the patient before you talk about going down on the audit, right? They're not going to just be like, yeah, sure, go down on my morphine, because they don't know you, who are you, right? Like, they don't know that you're doing that in their best interest, right? Go in there and build a relationship and figure out how to do it fast, right? Like, it's not magic, right? But, like, and so my first question to this person was, well, have you ever taken care of anybody with cancer? Have you ever taken care of anybody who had a double lung transplant? Right, I just listed a couple of examples. What I use is the same thing that I'm using when I'm taking care of somebody with like opioid use disorder. It's like the same type of skills that I'm using when I'm like literally on the street trying to tell somebody that they need to take a medication for high blood pressure. And what is that? It's communication skills. It's essentially, how do I communicate with someone who doesn't know me, right? And has no reason to believe me, because who am I? I'm not your mama. I'm not like, you have Cameron, you have literally no reason to believe that I have, besides your own faith, right?
Yeah. Yeah.
And a lot of time, what it requires is time, right?
Yeah.
What we know is we work in a system that is compressed. We don't have as much time as we need to really provide the most compassionate care that we can. And a lot of times, like, you figure it out, right? You use different shortcuts. I mean, I've written a piece. I remember as an intern sobbing in my director's office. This is too hard to be able to deliver the care that I want to deliver for all of my patients, and also go home on time. Like, it's just like, it's like, the moment, let's say I have one patient with schizophrenia, right? That one patient is going to take me 30 more minutes to convince that they need to take whatever medication, or that it's okay that I'm going to draw labs, right? And I love being able to do that. I love being able to, like, I walk into your room, and I think my patients know this. If you've ever been in the hospital, I sit at the foot of the bed. I'm not standing up, right? There's just little things that you can do that, like, kind of close that power differential, or at least you can attempt to, that convey to a patient that, okay, you care about them. But a lot of that is baked into how much time you're able to spend at the patient's bedside to really communicate with them, really use those motivational interviewing skills to get to the bottom of, like, why they don't want to move the morphine from the center.
Yeah.
Why do they not feel ready to go home tomorrow, even though it's been 10 days and technically the vaso-occlusive crisis is over, like, physiologically, right? Like,
Yeah.
but why don't we have, is healthcare in this country profitable?
Yeah.
And so
Yeah.
this is what I'm saying, like I like to think. And so my dream is to live and work in a system where healthcare is not thought of as an entity that should be profitable. I don't think
Right.
that something that is as essential as healthcare should be thought of as profitable, because for as long as it's profitable, right? What does capitalism do? You want to make things more and more and more efficient to make extracting profit out of it, which means that you're squeezing the doctor, you're squeezing the nurses, you're making everything really lean, right? So it's like so you can maximize how many patients somebody can see in a day, right? Like
Mm.
I make it up. Like when I do urgent care, I have 15 minutes to it's insane. Uh, all it takes is a little bit of a complex problem to just derail my day. So I think I want to study systems where profit isn't such a big driver of healthcare delivery, just to kind of see how people are doing as doctors and nurses and patients in those systems. Because I think, yeah, it's the biggest thorn in the side of medicine.
Got it. Okay. That actually perfectly brings me to my final question, because in real time, I'm sort of changing my mind. I'm sort of changing what I think. So I'll just tell you, my initial question was going to be like, what do you think is the sort of like most important factor in terms of sickle cell advocacy? And let me explain what I mean. For me, something that we spoke about in part one, and that Cass is really familiar with, is that in the sickle cell community, like so often we will shy away from speaking about like the race aspect, the social justice aspect, the discrimination aspect, despite the fact that we all know it's true. Like we will all be sitting around talking amongst each other, but the moment there's a panel, the moment that we're in front of mixed company, right? Folks want to get shy about it, or they want to tiptoe around it, or like I remember specifically one time, folks were sort of tiptoeing around it. They were trying to find out like, well, NFL does this for breast cancer. Why can't we get Major League Baseball to like sponsor sickle cell? And like immediately I was like, that'll never happen. That will never work, right? Like, and not because I'm pessimistic, but because like I understand the way the U.S. works in ways like a lot of people don't, right? And so the people on the panel were trying to explain it without being very explicit and stating it, and it kind of like took me waiting for everybody to finish and being like, hey, so sickle cell is still seen as a Black disease. Like let's just be clear here. Let's name the thing, like let's just say what it is. And like the number of people that I got who came up to me after that and was like, you're so right, like that is so true. I don't really like talking about it, or I didn't want to say it, or I'm glad you spoke. But they won't say anything out loud. Like they will not have these conversations, whereas I'm the one who's when we get the recommend, because sometimes they will recommend, like our older warriors will recommend, well, when you're not sick and you're not in the hospital, go back to the hospital, talk to the nurses when you're all dressed, don't go there looking this way, all these respectability politics, right? And you got parents and people nodding like, that does make sense, that makes sense. So introduce myself when I'm dressed well. And I immediately was like, stop. You would never ask a cancer patient to do this. Like you would never ask non-Black people to do this. Like this, we're not doing this respectability politics. Like we're just not, right? And my point is, I think the unwillingness to sort of like tackle that head on is going to really only delay the advocacy. It's only going to delay us reaching our goals. I think it is, for me, the most important aspect of sickle cell advocacy and making the changes that we want to see and getting to the future and the reality that we envision, that we think we need and that we deserve, right? And I recognize that I'm biased. Like I recognize that, because I had a very specific perspective early on, because I grew up in the suburbs and I went to private school my whole life and I was around mostly white people. And I thought we were poor growing up, Dr. Max. Like I thought we were poor. We were not. We were middle class, but because everybody around me was so friggin' wealthy, I thought we were poor, right? And I'm just offering that like for context. And like that's why I want to go to an HBCU, because I was understanding things at a very young age, thanks to that experience and thanks to my experience with sickle cell and in the hospital, that a lot of other people were not understanding. And I didn't always have the language for it, right? I often tell people like being woke or learning and going to school and studying these academic things is really just acquiring language to speak to our own lived experience. Like that's what I truly believe, right? Because I think anybody, regardless of your level of education, you can understand the systems that are at play. Like even if you don't always have the language to explain it and connect the dots. And so And so for me, that is the most important aspect. And most of the advocacy that I do focuses on that fact, because I would start off trying to explain sickle cell and talk about the science. And then I realized nobody really cares about the science. Nobody cares how cancer works. They just know it's a bad thing and they want to stop it. And like, so they're like emotionally invested, right? They know that it can affect anybody, anytime. You don't have to cause it. And so they care. So I really started to think like, well, what are the things that we need to change? What are the things that we need to do? What are the things that we need to focus on? And for me, the most important factor will always be social justice. It will always be tackling things like implicit bias, because the story you just gave about like sitting at the foot of a patient's bed or telling, you know, a doctor or medical professional, you need to go build rapport with this patient. You need to do it fast. I have since learned, and it wasn't until you said that I realized that this has been true for a minute. It's not the amount of time that the doctor spends with me. It's the quality of that time, right? It's what they're saying, what they're talking about, if they're listening, if they're constantly cutting me off. If, you know, I've had a doctor who came in and said, hey, how are things going? And I literally responded, not so great. I think that they're getting worse. And he was like, all right, sounds good. Well, I'll be back to check. And I was like,
oh my God.
but I just like, is this a joke right now? Right? Like, I'm like, did you hear? But it's like, so it's not because I used to, you know, kind of shade doctors a little bit, because I would say like, it's the nurses that do all the work. Like the doctors, they come in there for a minute and they don't really do much. And sometimes they get the medication wrong and the nurse has to correct them anyways. But then I realized, and it wasn't until, again, I started going to UCLA and I had you and Dr. Patel and my psychiatrist as well. My psychiatrist came to see me when I had surgery. Like, right? Like she had that wasn't her specialty. That had nothing to do with her, but she knew I was having surgery. She knew I was anxious about it. And she stopped by when she got off work, because she works in the same hospital, and visited me. It's like those little things that will make me trust somebody, that will make me like put my life in your hands, that will make me say, oh, I thought I knew best, but I'm willing to listen to what you have to say. Or, you know, I don't know. It's all those little things. So it's not the amount of time, but it's the quality of time.
I will say though, you're absolutely right. And that's, I mean, like, I round as efficiently as everybody, like, you know what I mean? But I'm also, I'm like, listen, I met this person X months ago. Within 15 minutes, they agreed to whatever plan to taper their morphine. And like, I don't have two brains. Yes, I'm Black. Like, yes, it helps probably. But like I could be Black and rude, and then that wouldn't work. Right. Like, but I think it's two things. The quality of the time is super important, but having time affects the quality of the time that you're able to spend, if that makes any sense. Like, if you are constantly rushed because you don't have a lot of time, you don't have time to think, right? You don't have time to actually think and assimilate like the information that you're receiving, because you're thinking about a million other things. You're thinking about all the other patients that, you know, your pager is going off. Like, so when I say needing time, it's both like, yes, it's nice to have a lot of time to be able to sit at the patient's bedside and like be there for 30 minutes if that's what's required. But sometimes it's just 10 minutes. That's 10 good minutes. For those 10 minutes to be good, your outside time cannot be stretched so thin, right? My ability to show up at when my patient is in the hospital, and put a blanket on them, because like I ain't got all that much power when they're in the hospital, because I'm not their hospital doctor. I can do that because I have time to do that, right? And it's partially because I'm a research doctor. Like I see patients once a week on average, or like 1.5 times a week. So like the rest of my week, it's not free time. The rest of my week I'm supposed to be doing research. But research is perhaps a little bit more forgiving or flexible. That I can be like, you know what, on my lunch break, let me walk up to Reagan and insert patient's name and just say hi, right? But if I were like a full-time doctor, like Dr. Patel, right? Or like a full-time clinician, rather, I'm a full-time doctor. If I were a full-time
I got what you meant.
Then like the time that when Dr. Patel answers the phone about somebody who's in the hospital, that's a patient that means there's a patient in the waiting room waiting. You know what I mean? So it's like it's a lot tougher when those pressures, like the sort of like productivity and profitability of the system, that is affecting your ability to even deliver quality short time with patients.
Okay, that makes a lot of sense. That makes a ton of sense. And I think that brings us to the end, because I think here's my final question to wrap this all up, because I completely agree with everything that you're saying. It also makes a lot of sense, and this is a prime example of why I say, like, I'm constantly trying to bridge the gap and I'm constantly asking questions, right? Because it's easy to just say, why are doctors in here for 2 minutes? Like, why do they come in and they leave right back out? They're not really addressing my problems. They don't remember my name. Like, it's easy to say that, and maybe they're just a shitty doctor. That's a possibility. But also maybe they're overwhelmed because they're trying to help as many patients as humanly possible. Like, I know that that's true for Dr. Patel, and still we want more from her, right? Because the really good ones are so few and far between. They're so rare. And so I think that that's absolutely true. I think there are a number of things. I think consistency is one, right? Like, there's a doctor, whenever I am in the hospital, he works with East West Medicine. I think his name is Dr. Andrew Shubov, I believe his name is. And it's his consistency, right? It's that he does what he says he's going to do. If he says, I'll be back at this time or between this time or this time or after this time, and I'll just come and check on you and see if you still, he actually does the thing, right? And again, we know things happen and that can't always be the case. But my point is, like, it's a number of things. It's also, he's not spending a ton of time, but when he is there, he knows, like, he knows that I'm on the spectrum. So he knows certain things to do. Like, he comes in, he's super chill, he's super quiet. There's another doctor who's like loud as hell, and I have to put on my headphones when I'm talking to him. So my point is, like, there's a number of factors that that play into that quality time. And I think that it's a good perspective and a good thing to know that, like, not all doctors have the same amount of, like, extra time or free time, or their time outside of you as a patient is not all the same. It's not all equal. And that often that they're doing the best that they can. So that makes a lot of sense. So final question here as we wrap up. If you could envision, and now, well, actually, wait, I have a preemptive question, because I just remembered this, because I was actually going to ask you about Juneteenth, but then I found out you grew up in Cameroon, so I
mean, it's okay. I went to HBCU. I'm black as hell. Like,
no, there's no doubt about that. You're definitely black. You're definitely hella black. That's for sure. So, but my question is, I mean, because at this point you're really familiar with the U.S. healthcare system here, right? Like, you've been here, you've been involved in it, you work in it, and so I think you do. I think you can speak to what it should look like, what we want it to look like, because what it sounds like from everybody here, from Cass, from Dr. Patel, from everything that you said, it sounds like what we need the most, and this even. I think even what I want to see different in terms of, like, the changes in implicit bias and the changes in like the social justice aspect, it seems like it's all about systems, right? It's like the systems that need to change, right? Like, even if somebody wants to do a certain thing, do they have the resources and the whatever necessary? Can they? So with that being said, if there's a way to sort of summarize, what does the world of U.S. healthcare, what does the one that we want, not the one that we have, not the one that we think that we're going to have, but the one that we want. Like, if we could design it, if you could design it, because this question is for you. If you could design it, I often talk about, like, I wish we had, like, a team of Avengers, a team of patient advocates who could just go and do these sort of things, right? If you had a team of doctors or medical professionals or whoever they would be, and you could design the U.S. healthcare system that you want, because, again, I think this is a lot about systems, right? What would it look like? What would it do? How would it function? What do you need to get there?
So I'm going to use a little bit of an anecdote to so I was talking about time earlier, and I can sort of go, it's not just time, but it's like time and, like, human resources. When I say time, it's really shorthand for a lot of things, right? In the same way that when people say, oh, there's no bed, it's really that there may be a physical bed, but there's no nurse to take care of you. So there is essentially right. So when I think, so I'm going to use a small anecdote, right? When I was in residency, I did this kind of like 360 study where I interviewed patients, nurses, doctors about sickle cell care in the hospital to understand everybody's perspective. And I'm analyzing the data right now. And a patient might say, oh, they're never on time with my pain medication when I'm in here suffering. That's very valid. You're in your right to feel that way. When your Dilaudid is due, it's due. And if the nurse is 15 minutes late, that's 15 extra minutes that you're suffering. And that's like, so if you're getting Q2 Dilaudid. Now, you ask a nurse, they'll tell you, well, it is really tough to be able to stay on top of somebody's Dilaudid every 2 hours, because here's how you administer Dilaudid. You're supposed to check on patients' pain symptoms, then you administer the Dilaudid, then you got to come back in 30 minutes to check back if the dose that you administered was effective, right?
That's not counting
but-
going to get the medication, drawing it up, and doing all that, scanning it in, making sure your wristband scan, all those little things that I think about somebody with ADHD. Yeah.
And so then this nurse was like, you end up actually being in the patient's room every hour, not every 2 hours, right? Between like coming back and checking in on the symptoms, and sometimes needing to like page the intern or whoever and be like, hey, this is actually not working. Can I get an extra milligram or whatever? But being in a patient's room every hour is like medication. It's not like antibiotics where like you administer the antibiotics and you're gone. You don't need to come back and check on how somebody's doing.
Right.
You need to come back and check if you're administering something for pain or nausea or itchiness. You got to come back and check how the patient's doing, right? But when this nurse walks out of that room, she has like a 70-year-old next door who she needs to turn and or whatever. And so sometimes they'll be late. Maybe 15 minutes late. And then there are nurses who are super apologetic. And so one of the nurses tells me, no, I think my patients understand. They know I'm trying my best and I'm super apologetic. But it's the same nurse who also tells me that when she has like, she's like, a lot of these patients are my age. Nurses be so young. So a lot of these patients are my age. So they're watching like or whatever. I ask them, and we talk about it, blah, blah, blah. It's the nurses who are building relationship with patients outside of the care that they're providing, who the patients also understand when they're late with the medication. And it's the same nurses who are apologetic. There are nurses who, I'm not saying that their approach is right or wrong, but they would just flat out tell you, I'm sorry, I can't be in your room as often as you need me to because I got another patient next door. And that's why I'm late. They'll just tell you. It is very matter of fact, right? But like as a patient, it doesn't feel good to be told that the reason why your medication is being administered a little late is because like there's somebody else. It almost lands as like, well, does my pain matter to you, right? It's a systems issue, right? It's actually a systems issue. Shaping individual behavior, right? In a way then that patients receive as like, oh, this nurse is racist because she just told me. But it really isn't so much that the nurse is racist. She's just like maybe a little more matter of fact and maybe a little less of a warm person, right? And it sucks that she has 3 patients to take care of. She needs to administer the audit every 2 hours, right? It's like the system at the top is dictating the amount of freedom that this nurse has, right? To actually be able to show up on time. And if it doesn't show up on time, you as a patient might experience that as like, oh, if I had cancer in here, y'all would be running in here all the time, right? Which is the case sometimes. It's true. Like I've had patients who are like, yes, I've been in the room with a cancer patient, and I see them running in here whenever they scream, right? That's also a truism. But in a lot of instances, there's this kind of like sublimation of the structural, right, to the interpersonal. Essentially, people are experiencing the violence of the system, but I'm perceiving that as like a failure of the individual nurse or doctor in front of them. You make more resources available. More nurses. I mean, I was talking to one nurse who was like, oh yeah, I float sometimes with unit patient. They get an extra resource nurse to help them because with acute leukemia, drawing labs really often. They get an extra resource nurse over there. They spend their time on TikTok, and when we're over here, we don't have much resources, right? But why? It's because cancer care is more lucrative, right? Like there's more money available to support the staff who is providing cancer care. So. And why is cancer care more lucrative? It's because the cancer drugs are so goddamn expensive, right? And so my dream is for us to be in a system where cancer care is not inherently more lucrative and therefore resources than like hematology. And we might be very close to that because
I think we are. Exactly.
It's actually, I am waiting to see it manifest, and it kind of infuriates me actually, right? I mean, the reason why so many hematology oncologists do not want to do hematology historically is because it's okay as well, right? It's like, oh, you get to do sickle cell where like there's no resolution to the problems. It's a lot of uncertainty. People are in pain all the time, and they don't pay nearly as well as doing oncology.
Yep.
Like your average person does not have sickle cell, right?
Exactly.
But in the pediatrics world, it's a little different, right? Because cancer is rare in children.
Right.
So if you're a pediatric hematology oncologist, you can't just choose to only do cancer most of the time.
Right.
Because there ain't that much cancer to go around on children. Right?
Got it.
So I think resource allocation is super critical. I want us to have more nurses on staff. I want us to have more doctors on staff. If you even look at the evidence, right, when you look at what is the most effective way to reduce the impact of like implicit or cognitive biases on diagnostic and therapeutic accuracy, essentially, like mistakes, like delays in figuring out what's going on with someone and figuring out the best with someone based on their race or gender. It's having two doctors instead of one. Which hospital is going to do that? Right?
Yeah.
It doesn't inherently make business sense in the hospital system to like allocate more than one doctor for given, you know what I mean? I mean, there work around that, right? Like I think medical trainings, in a way that's like you have like an attending and you essentially have 3 eyes to think about patients. There's some ways in which that already happens, but I think in general, allocating more human resources to our healthcare system.
Got you. Okay. Yeah, I think that makes a lot of sense. I've learned a lot. I think this really sort of like affirms like what I've been thinking lately in terms of I know that what we need is like major systemic change, and doesn't it always come back to capitalism? Amazing,
right?
But I think, yeah. So it sounds like we need systemic change, but what I also heard in there is like there are some opportunities for harm reduction, and what I mean by that is like I think. So like I said before, like I want to be my nurse's favorite patient, right? In that moment when they're like, should I put my break off for like 2-3 minutes or whatever? Or no, I'm going to go give my, I've had multiple nurses tell me like, oh, I'm supposed to be on break, but I just wanted to give you your meds before I went on break. And it's like 2 minutes early, but I just want to make sure you had them. Or they more often will do the thing where they'll say like, hey, I got another nurse to cover for me. I have to go to break right now, but I know your meds are due in like 7 minutes or 10 minutes or 20 minutes. And I've already told them they're going to be in here at this time. If they don't come, call. Like I have had nurses who will do that, who will say that. And I think that, again, like with me being like autistic, I tend to miss a lot of like, I don't always know if they're frustrated or if they're mad. And so I will try to pay attention to a number of things like body language and facial expression, not just tone, right? To know like, are they frustrated or whatever. But so, and I'm saying that to say like, the nurse who says it really matter-of-factly, that's not going to bother me. That doesn't. Right. Now, I know that might bother a lot of people, but for me, that doesn't bother me. And that is not something that will ever lead me to the conclusion that they are racist or dealing with implicit bias. It will be their lack of communication. It'll be what they say, not how they say it, that will lead me to that, right? So a nurse who is like, I've had ER nurses who are just very flippant about when meds come and like, oh, well, yeah, like they just don't care about the time, which to me, in my mind, leads to me thinking either you don't understand the importance of me getting the meds on time, because it's not like, I think a lot of nurses think like, oh, you just want them because you just want them, right? Like, well, yeah, because I'm in pain,
because I'm suffering.
Also like, right. But then also like, I feel like I don't want to play catch up. Like sometimes that's what it feels like sometimes, right? Like the meds start to wear off and then I don't have anything else. So it's the nurses who communicate to me that they understand, what I'm dealing with and that they believe me. And, it's those nurses who I give the most grace. It's those nurses who I will sometimes be like, and they'll be like, oh, I forgot. Why didn't you call me back? Or, if I need something, I'll say, hey, just bring it next time you come. Like, you don't even have to go get it now and come back. Like, I am like the most like forgiving patient, but very often it's to those nurses who give me that same grace, who show me that same grace. And I have to say, like, at UCLA, I get that pretty often. It's pretty rare when I have issues there, because like I said, they do have the sort of like float nurse. They usually have one nurse who isn't assigned to any rooms. They're sort of just covering, like filling in the gaps when they arise, when they inevitably arise. But again, UCLA Hospital, UCLA Health System has a bunch of resources. They have a lot of resources that other places just don't have, that they may never have, like until we get universal healthcare, right? And yeah, just like you, pharmaceutical companies, like the executives work at pharmaceutical companies, they're very interesting. And I understand now why they have community liaisons, because sometimes they tell on themselves, right? Because I said this in the first, in part one, about the pharmaceutical company who invited us out to talk. They were saying, hey, we're about to get into gene editing, gene therapy, and we want to hear from the community, what's most important to you guys, and blah, 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 so forth and so on. And then I will never forget, they put out this tweet that basically implied, like, it wasn't the same pharmaceutical company, but it was another pharmaceutical company soon after, that basically implied, like, oh, the money's here now, we can start working on sickle cell treatment. And that is essentially what was communicated in so many words. And I'm like, as much as I should be like happy about that, you're reminding me of the disparities in the first place. Like, you're reminding me that there's an issue. You are confirming that you haven't been working on sickle cell treatment and care and therapies because there hasn't been money in it. I can't even be mad, but like, that's what you're saying. Like, sometimes I don't even think that. Yeah. So I think that makes a lot of sense. So it really sounds like we really need to work on these systems. And I guess I don't know, you might not be the best person to ask this, but it sounds like we need to work on changing the systems, but it sounds like there's potential and opportunity for harm reduction in the meantime to sort of like improve the overall quality of life of people living with and dealing with sickle cell. If somebody wanted to help, if somebody said, I got extra time, or I got extra resources, or like, for example, like I have my template that Dr. Patel was just talking about. Like, it's like a binder, and it's got like every single doctor that I see, it's got their full information, and the last time I saw them, and like any possible question you might think to ask, or questions you don't even think to ask that you might, but information that might be useful, it's on this spreadsheet, right? And I've shared it with a few people, but I'm like, how do I get this to the hands of more patients? Because I think they would benefit from this. Because how many times do you go and you're trying to remember a doctor's name, you're in pain, you're in the hospital, you don't know the last time you had that, you don't know your typical dose, or you don't know this, or you don't know that. And so even me, somebody who's firmly in the community, who I consider myself an advocate, and I have for the longest, I don't always know like how I can help. Like, I know, like, oh, I have these resources, I have this help, I have this extra time, I have these extra spoons. How can I help? So that'll be my final question for you. How can somebody help you do what you're doing or what you want to do, whether that's with your research or in other ways? And then if they want to get in touch with you, what's the best way to do that if they have questions? And I did see that you linked this article here, which we're going to add to the description. But yeah, how can somebody help, and then how can they get in touch?
Great question. I think you and I should talk more about this binder of yours, because actually I think there's a potential opportunity to formalize it into like a toolkit for people who are transitioning into adulthood. I take care of young adults, right? A lot of the patients I have are in their like 20s, 30s, starting to get some referral from Children's Hospital. And I think like I am not a pediatrician, right? Dr. Patel is. She's a pediatrician and is an adult doctor. I think like the philosophy in pediatrics is a lot different than the philosophies in adult medicine. Like I told you, I tell my patient, I mean, I don't always say it out loud, but like to me, as a patient, you're allowed to make bad decisions. Pediatricians, right? Like pediatricians want to hold your hand through every decision. And so like, I mean, you're my patient. I've called you before when you've missed an appointment, but that's out of courtesy. I ain't got to call you back. I don't have to, like, not back, but like what I mean is like, if you miss an appointment, I'm like, well, they're an adult. Maybe they got something going on, right? That's like the average disposition of an adult medicine doctor. Oftentimes it's like, if the patient missed an appointment, oh, they probably got something going on, or they forgot, right? And it takes me being like, what's going on with Cam? She usually is on time or whatever, and be like, let me call her, right? But that approach is not sustainable for me to be able to take care of every single one of my patients. I can't call everybody who misses an appointment. And so I think like teaching late age adolescents and young adults to like navigate the health system when they become adults uh, is probably really important as a kind of harm reduction approach, because it'll be a while before like every, like we have all the social work, or like Dr. Patel said, right? We need assistance change. We need more like resources at the adult system. Uh, but uh, I think the one alternative is sort of like empowering the, I mean, and I don't like doing this libertarian thing where you're like, where people have to essentially carry, lift themselves up by their bootstraps or whatever, to get through a health system. But I think a way for people to sort of think about, how do I navigate the system really well, uh, in a toolkit, and like maybe a video or something, I don't know, would probably really helpful for a lot of the transitioning adolescents, because it is in early 20s that you see a big jump in like morbidity and mortality in sickle cell disease. Part of it is because people fall through the cracks when they leave the pediatric universe, where like your doctor really holding your hand the entire time. I ain't doing that over here, right? Like,
Yeah.
yeah.
Yeah, that makes a ton of sense. And we should talk. We definitely should. Yeah, I think there are a good number. I just brought this on screen because this is kind of like the template that I'm talking about. It's not helpful. I wish I could show mine. I might show mine at another point, and I'll put a link in the description if you do have sickle cell, or anybody, because I actually sent this same template to Krista to use for her and her kids. So you don't necessarily have to have a chronic illness, but it is helpful. It has room for like all the specialists and stuff. And I bring this up because part of what I'm saying is like it's really hard to see like just how much information is on there with just this box, but
Right.
it's something that even Dr. Seal mentioned, is that like a lot of times it's the little things that make such the biggest difference, right? Like I often feel like, oh, I wish I had a personal assistant, but not for my work, to help me manage my healthcare, to help me manage my
Right.
chronic illness. I often say that managing my chronic illness is like having a part-time job, because I'm putting in at minimum 20 hours a week doing it, between appointments and scheduling and making phone calls and sending messages and a lot of the things that are extra challenging for me as somebody on the spectrum and with ADHD, or who's neurodivergent. And so with sickle cell, you have a ton of comorbidities. So you don't always have the spoons, and you might not always have the resources. And, especially if you don't get a chance to work full time, then you don't have as much financial resources as another
Right.
person. And like, there's all these factors, right? And that's on top of being very likely a person of color in the US. And we didn't even, tackle that, but it's just really, really complex. And so I was just very interested, and I really appreciate you for joining this conversation, because I've been interested for quite some time in what sickle cell advocacy can teach us in general about solidarity, about the systems at play, about social justice, and the fact that the more that we approach sickle cell advocacy through a social justice framework, the more progress we make in both regards, both for sickle cell and then like for social justice in general. And I think no book speaks to that better than Body and Soul, the book that I was telling you about, or that you mentioned, that you're actually already familiar with, that I mentioned early on. So I really appreciate your input in this conversation and joining us. And yeah, let's talk for sure. If there's something that I can do, that I can help in any way, I want to. As much as I hate school, I have been contemplating going back to school if it means I have to get some type of certificate or some type of degree to do the things I want to do, which is to help more within the community, but on a much more like interpersonal, one-on-one level, like to help people in very tangible ways, and not these more abstract conceptual ways that I've been doing in terms of like giving speeches and workshops and whatever else. I want to be like, hey, I got this template, use this template. I put this binder together. Here, let me show you how to do it. Or how do we like get a bunch of binders and give them to patients, like, right? Or when patients get diagnosed as a kid, like, why isn't there a standard program across the board that says, okay, you've been diagnosed, this is kind of what you can expect. Here are some basics. I was talking about that in part 1, where you have patients on Reddit who don't know that a heating pad is probably one of the most common ways that people with sickle cell treat their pain crises, right? And so somebody's like, oh, a heating pad, I'll try that. How have you been diagnosed? How have you been living with sickle cell long enough to hop on and log on to Reddit and ask this question and don't know that heating pad is a basic bare minimum fundamental education that I am now realizing is a privilege that I had that I thought that everybody had. And then the last piece of that would be, again, bridging that gap and like helping warriors to understand the perspective of medical professionals and helping medical professionals better understand the perspective of warriors. Like, well, this is why I got mad. This is why I snapped her. This is why I said this. This is why I responded that way. And, and here's how I can maybe respond better. And, you don't have the tools to express your, like all of these little things that I'm like, oh, somebody helped me with this. Somebody guided me in this way. How do we get that for other patients? How do we get that for the community? Okay, so lastly, if somebody wants to reach out to you and connect with you, maybe they want to give you kudos, or maybe they want to see how they can help, or maybe they want to donate a bunch of money. They want to donate $1 million to you. How does somebody get in touch with you?
I don't have no way to receive no money, but get in touch with me. Let's see. You can easily find me on the UCLA website. Like my email is on there. And
that is true.
And then the other thing is, I'm on social media. I'm at I'm Max Jordan. I'll type it in here. Max Jordan _N on Twitter or X, whatever it's called these days. I'm like pretty active on social media. And it's not like a professional Twitter by any means. I tweet about work, and I tweet about life, and I tweet about movies. I tweet about all kinds of things. And I have a Substack. Like, people want to subscribe. Like, I write about health and politics, like that article. It's called Adverse Reaction. On Substack. I actually just wrote a piece you might find interesting on female surgeons and patient outcomes, because you mentioned earlier the thing about female doctors. So I'm at Substack.com.
Okay, sounds good. So so we got a few things. So all of the information that Dr. Max just gave will be in the description box below, but it'll also be in, we always put together a master document for each episode that we do. I'm going to see if I can, so you know what to look for. Let's see. This is, now StreamYard wants to take me somewhere else. And so this is kind of what it looks like. That's not helping. But it'll be there, essentially what I'm saying. So any assets that we used, anything that we mentioned today, the books that Dr. Max mentioned and recommended, the books that I mentioned and recommended, information to contact our guests will be there. So his social media handle, as well as his Substack, will be there, and any sources that we use to do research on this, or like if I stated a statistic, I will put information. It will all be linked here, so you'll be able to find that. And this document will be linked in the description below, so you'll have it all right there. And you mentioned like the female surgeons. I don't know if you've heard, but apparently a lot of people are just now finding out that it is legal in 29 states. I can't do math. It's only illegal in 21 states. So whatever, 25 plus 4, 29 maybe. I think I got that right. It is legal in 29 states to do a pelvic exam on a woman while she is under anesthesia, if she's already under anesthesia for a surgery. Now I knew that, which is why I flew my friend Krista out when I was having surgery, because I was terrified to sort of like be solo in the hospital. But when we still have sort of like what to me is a very archaic, outdated law policy thing that's okay, like even if it's on the books still legal, why do we have people in medicine who are still willing to perform pelvic exams on patients without their consent? Like, when we talk about changing systems, why is that? Why does it seem like in so many ways that medicine is moving so fast and improving so fast, and then in some ways,
slow. This is something I've thought a lot about, because I actually used to want to be an OBGYN, and then I decided that their lifestyle didn't really match what I wanted for myself. I think I'm going to answer this and then I got to go. So when you're undergoing surgery, you consent to a bunch of things, including trainees being involved in your care, what have you, right? Let's say, and if you're having, and by the way, this only happens if you're having pelvic surgery. Let's say you're having like your gallbladder removed, right? Or I don't know, like a colectomy, some kind of abdominal surgery. It's likely that the surgeon is gonna like show the anatomy to the trainees who are in the room. Like, here's what a gallbladder feels like, or whatever, right?
Right,
Or
of course.
this is what bowel feels like, or like they
Yeah.
may like surgeons let me staple bowel at the end of a bowel resection, right? Like,
Yeah,
here's
that
how it
makes
feels like
sense.
to staple a bowel, right?
For sure.
The value there is that there's like some kind of educational value in
For
you
sure.
knowing how this like specific like structure in the body feels like or looks like or whatever. The patient who is undergoing this bowel or gallbladder or whatever surgery has consented to having trainees participate in their care. Usually, like if you're at a teaching hospital, it's part of your,
Yeah.
it's always part of it. Like, this is a teaching
Yeah.
hospital, there will be trainees involved in the care, involved in every step of the care, including, I don't know, touching your gallbladder, blah, blah, blah. Now, so flip the page, think about now gynecological surgery. It's the same thing. The idea is like you will have trainees involved in every step of your care. And typically at the beginning, so I've been in a ton of hysterectomies, right? Like at the beginning of a case, there are a couple of things that happen. Typically, I mean, it depends on the case, right? And
What about wait, what about the cases where there is not gynecology? So because what I heard recently, and this is what I've heard a long time ago, so this is not correct, let me know, but I've been the word going around, this is coming back up in social media, so that's kind of why I brought it up, is that if you're under anesthesia and you're just having your tonsils out, it's got nothing to do with anything below the
absolutely
tonsil,
not.
that pelvic exams are still legal to be performed without the patient's consent.
Well, I don't know about the legality or whatever, but I have a very hard time envisioning a situation where you're undergoing a tonsillectomy and somebody's doing a pelvic exam on you, because
I gave that example because that was the example given on social media from a doctor who was recently a med student. I don't know if they could be lying. I'm just saying that's
they may
what's
be
the word
dramatic,
going around.
like because the person,
Okay.
think about it. Who's doing a tonsillectomy? It's an ear, nose, and throat doctor, right? The
Yeah.
last time they did a pelvic exam was when they were in med school. Like,
Right.
so who is going to supervise you doing this pelvic exam, right? So
Right.
the only time I have ever seen a pelvic exam done under anesthesia was when it was a gynecologic case, right?
Okay.
It was essentially, it was pelvic surgery, right? Someone
Okay.
is slated for some kind of pelvic surgery.
Okay.
And the lead doctor in this operating room is an obstetrician gynecologist, usually, or a gynecologist, whatever. And so there are a couple of reasons why those exams happen. First and foremost, usually if you're going to operate, let's say you're doing a surgery for fibroids, right? The resident who's probably going to be leading the case should get a feel of like before they cut you open, like, oh, like how high up is the uterus, and usually you sort of do a pelvic exam to get a sense.
Yeah, no,
of
that
like
makes sense,
right?
Yeah.
And the alternative is sometimes you're doing like an ovarian cyst case, right? So maybe the uterus is healthy, or whatever, but the other, like one part of the teaching in the pelvic exam is that you only get good at doing pelvic exams by doing a lot of them.
Yeah, that makes sense too.
You don't, and so it's, the notion is like, even in a patient who is undergoing a gynecologic surgery, if they have a normal pelvic exam, or if there are variations in the, like some people have a retroverted uterus or introverted uterus, some people's cervix is like really posterior, right? Like, so the idea is essentially like, it's I think a lot of gynecologists think of this as almost the same thing as like your abdominal surgeon showing a patient what a gallbladder looks like. The gynecologist who is teaching someone to do a pelvic exam before pelvic surgery is not ascribing any kind of value. It's not ascribing to it any sexual value, if that makes any sense, right?
Yeah,
They're
for sure.
essentially just like teaching, like, this is what a normal pelvic exam is like, or this is what an abnormal pelvic exam is like for someone who has fibroids or whatever, right? Like, so
yeah, no, I think that makes sense, and I also think that that's valid, right? I think the concern was twofold. One, the lack of consent, like the lack of awareness. I know, like when I had my uterus yeeted, I had very specific and frank conversations with my doctors, but a lot of that has to do with like previous sexual assault in the hospital, and so I really wanted to be clear about who was going to be in the OR, who was going to be touching me where, doing what, right? And so I had an amazing OBGYN surgeon. So I think it's twofold. It's like the consent or like the lack of awareness. And then two, if you're operating on my tonsils, you have no reason to be near my pelvic. And I do
Right,
see that there's
exactly.
value in terms of like the medical student or the resident or whatever. But especially as Black people, as Black women, dealing with the healthcare system that we've dealt with here in the US, and the experience and being, like, sterilized against our consent and all these kind of like foolish things. It was just the consent part and the idea of like being a guinea pig or a practice, body
That feels
for
icky.
some medical student and not knowing about it or not having any say in the matter. And yes, that feels like super, super icky. But you're saying
Yeah.
that that's very unlikely to happen.
Yeah, I mean, I and again, I can't speak to. I went to Yale for med school. I know, like, and actually, there was a piece. I think it was Elle magazine and it was a Yale resident. But when she wrote this, I think she was a med student at Brown, and then was a emergency medicine resident at Yale. But I think she might have been writing about her own experience as a student at Brown, but like she might have interviewed some students at Yale. But I think in general, I think most like the gynecologists, there was this kind of like assumption that if you have consented the patients to undergo gynecologic surgery and told them that there will be trainees involved in their care, that it is implied that like the trainees might participate in an exam of any sort of like part that is like relevant to your gynecologic surgery, right? I understand that because of the society we live in, pelvic exams to non-physicians have a particular valence as it relates to sexual assault and to sexual assault. It's my understanding, just based on reading comments on social media, is that people would actually like to know whether or not, like, specifically, like, is somebody going to do a pelvic exam on me? But and I guess that's up to sort of like bioethical debate, right? Like, should we assign a unique value to the pelvis compared to any other organ in the body? Does that reinforce? I don't know. Like, does that reinforce certain notions in our society? I don't know. I mean, I think if most patients or if most people who are undergoing gynecologic surgery feel like the consent should explicitly like spell out that X, Y, and Z trainees are going to also potentially participate in the pelvic exam, then bodily autonomy, it should be listed in. But the perspective of a gynecologic surgeon is really that to them, the pelvic is another organ, or rather, like your uterus. Well, they're like, whatever. This is one organ like another. They're not assigning to it any particular value.
It's not being sexualized in that way.
Exactly, it's not being sexualized.
To have the same,
exactly.
I got you.
That's how I understand that issue.
Gotcha. Okay. Well, I appreciate it. We are over time, so we're gonna get up out of here. But I think it was well worth it this time. We learned a ton. I feel like I owe you tuition money, Dr. Max. I appreciate your time. I appreciate everything that you taught. I appreciate everything that I learned about you. I really am impressed. I often say that I do what I do because regardless of like how multiply marginalized I am myself, that there are people more vulnerable than me, right? There are people who are even more marginalized than I. So I know what my lived experience is like, and I can only imagine like what it is for others. And so that's why I keep doing what I do. And it really just sounds like the same is true for you with the work that you do, and that you're talking the talk and not just walking the walk. And I really appreciate that. But more importantly, maybe most importantly, I really respect that. I think it says a lot about you, who you are as a person, about your character, who you are as a physician. And for me, like I couldn't recommend you enough. So I really appreciate you coming here and sharing your wisdom with us and offering us some value. And I appreciate it and look forward to speaking with you more about much of what we talked about today.
Thank you. Very kind of you. Thanks for having me. And I hope, whatever I shared is helpful for your audience.
Absolutely. Absolutely. Thank you so much.
All right. Bye-bye.
Bye. Whew. All right, y'all. We're going to get up out of here. Oh, I kind of like this. like usually like it's like widescreen, but I kind of like this square right here. I don't know how that happened. I don't know if you did that, Krista, but I kind of like it. You can kind of see the sickle cells. Well, you can't see my hand, right? Okay. Anyways, we're gonna get up out of here. We would have actually been on time. Chris, I don't know. Can you hear? Anyways, we would have been on time. Except there was just so much to offer. Like Dr. Max kept adding value to the conversation, and I am super grateful for that. Y'all just don't know. Like this has been the most difficult episode to schedule, and when I say like difficult, I don't mean like just for Black and Sick. For those of you who don't know, like I'm a producer, so I've been doing producing for a while, like since my late teens or whatever, right? And so different projects require different things, and I love this because I enjoy every aspect of it, right? But like the scheduling and like asking people for their time is one of my least favorite parts. And so this one was pretty complicated because, like I said, they're all very busy. They're all in very high demand, doing very important work. And I could not be more grateful that they have that they decided to give us some of their time to impart some of that knowledge and some of that wisdom. And to join the conversation and to keep the conversation going. So we're gonna get up out of here. I'm not gonna talk too long because I'm hot. I done started to sweat. My water bottle is empty. I need more water. My mouth is now dry because I've been talking, and it's still hot outside. The sun is gone, but it's still hot. That's not typical in California. We usually lose our heat when we lose the sun. I don't know what's going on. Climate change, I guess. I don't know, but it's hot as hell. I got my windows wide open, my door wide open. Apologize if you heard the noise, but that's how hot it is right now. And so I'm gonna get up out of here. Krista, was there anything that you wanted to say to the people before we get out of here, or should we just dip, or what's up? I don't think here, let me do it like that. I was gonna say can I add you without adding you, and I don't know if I can. I'm gonna edit all this out, by the way. Hold on. Turn your camera off real quick. I want to see if I can do something, or just like yeah. Okay, yeah. See, that's what I thought, but okay, I can do it. I was able to do it. Okay. So one, you can turn your camera on if you want to. But
can you hear me now?
I can hear you. Okay, and the people can also hear you. So that's what I was trying to figure out, because I didn't want to like put you on like on the internet if you was like, hey, I didn't sign up to be on the internet today. So that's what I was making sure. I wanted to test that before I actually did it. But like I was saying, before we get out of here and I go cool myself off, was there anything that you wanted to say before we did?
No, it was really just an enlightened conversation. It gave me insight as somebody who deals with chronic illness and the medical system. And so I'm just excited to be in the room. And yeah, I agree. We got to dip because we're here in Dallas, and I'm pretty convinced that the devil has his ass cracked sitting on the state of Texas right now.
Bruh,
so
just farting. Like, if they act on the state of Texas, it's pointing towards California. It's pointing towards LA, and he up there farting because
you getting crop dusted. That's what's happening.
That's what's happening. That's absolutely what's happening. It's wild, bro. Like, I'm waking up hot, like going to sleep hot. Like I'm usually, it cools down at some point. It's not even cooling down. It's just like, nah, we just gonna stay hot.
Nah, girl, it rained today and it's still gross outside.
But you know what? I try not to complain. I just was saying this to a neighbor. People call us spoiled out here in California. I'm okay with that. You can call it whatever you want. I think we have the best weather in the U.S., especially for somebody with a chronic illness that is triggered by cold, extreme temperatures, too cold, too hot. It could be deadly for me. So I'm grateful. As much as I complain and talk crap about, what's happening here in LA and California, I am grateful for the weather in general. Also, before I go, I gotta say, Krista, you did the thing that I would say like 99.98% of guests or people do in general. So usually, I brought this up last year, I think. Usually if you ask somebody, and you got to try this at a meeting, try it somewhere. Usually when you ask somebody, was there anything else they want to say or any last words or anything else, they will say no, but then proceed to say something. Right. And it wasn't until like I was watching back so many of our streams that I realized like how many of us do that. Like, any last words? And we'll go, No, that was a really great time, and I really like we all do it, and I don't know why, and I'm fascinated now to the point where I recognize every time somebody does it. So the next time you're like in a meeting or you ask somebody for the last words, pay attention to if they say no, like if they respond, you say any last words, anything else you want to say, they will say no, but then still say something or say some last words. Where if they really had nothing else to say, they just be like, no, I'm good, right? But that never happens, and I think I know why it happens, but I'm curious if anybody knows like the psychology behind that or what that is about. Let me know. I'm really curious. And I'm
Now
weird,
I'm curious.
and I find stuff like that fascinating. So yeah. Okay, that's it. That's it. Thank you so much y'all for being here. Those who showed up live. If you're wondering, we haven't been promoting the lives because we're just kind of getting back into the swing of things and sort of like teaching Krista the ropes and how it goes and all streaming. We're going to be doing a lot more streaming, but we want to be able to do it with like less pressure, right? And until we get our till we get where we really want to be. So if you're wondering, like, how come there's no promo? How come you're not saying anything on social media? There's a reason for that. So just hang in there, stay tuned. I appreciate anybody who showed up, who came through. We're gonna get out of here. Okay, see, I'm done. I'm out of words for the night. Peace, y'all. Sat Sri Akal, Waheguru Ji Ka Khalsa, Waheguru Ji Ki Fateh. Peace. Oh, did I miss a comment? Please don't tell me I missed a comment right as I'm about to end the live. Oh, it's upside down. Thank you. Appreciate you. Okay. Now we're getting out of here.